Okay, friends, so I guess you know me pretty well. I'm Dr. Sushant Soni. I'm MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. So let us start. Let us start with the General Pathology Rapid Revision module, starting with our first topic in General Pathology, that is cell injury. It is much on the easier side, so I'll be going slightly faster in this. In our this module, we will take care of cell injury and inflammation. So starting with cell injury, you very well know that normally the cell is in a state of homeostasis. It is able to perform all its functions well. In case of stress, it undergoes adaptations. There are four cellular adaptations, which are hypertrophy, hyperplasia, atrophy, and metaplasia. If the cell is able to adapt, fair enough. Otherwise, it undergoes cell injury. Now, cell injury can again be of two types, that is reversible cell injury, reversible and irreversible. Irreversible cell injury is of two types, that is necrosis and apoptosis. We will be having a look at all these terms one by one. Starting with hypertrophy. You very well know it is the increase in size of cells, and apoptosis. We will be having a look at all these terms one by one. Starting with hypertrophy. You very well know it is the increase in size of cells. It's easy to remember, rank 1 to 3. Everybody gets one trophy only, size is different, increase in size. Size is increasing, not the number. So it is seen in non-dividing cells and does not predispose to malignancy. Does not predispose to malignancy. Next point, examples. Hypertrophy will be a feature of permanent cells. Which muscles are permanent muscle? They are skeletal muscle and cardiac muscle. Skeletal muscle and cardiac muscle They are permanent cells, as that is they are non-dividing, so they will undergo hypertrophy. So examples are muscle of bodybuilders, that is the skeletal muscle. Next, hypertension of faulty valves, that is cardiac muscle, they undergo hypertrophy. Next is uterus during pregnancy. Please note, uterus during pregnancy is combined hypertrophy plus hyperplasia. It is combined hypertrophy plus hyperplasia, but predominantly hypertrophy. Have a good look at this. Next, extremely important, breast and lactation. I can divide the female cycle into three phases: puberty, pregnancy, lactation. In the first two phases, that is breast and puberty and pregnancy, is combined hypertrophy plus hyperplasia. Both the number as well as the size is increasing. It is combined hypertrophy plus hyperplasia. Whereas breast in lactation is just the increase in size of cells. That is, it is hypertrophy. Number is increased sufficiently. This is asked. Next point, breast and uterus post menopause, atrophy. You know that. Next point. This gets us to the examples of hyperplasia. Which is the increase in number of cells. So it will be seen in dividing cells. Predisposes to malignancy. Examples. I can divide hyperplasia into physiological and pathological. Physiological. One of the most common is bone marrow. Hematopoietic cells in bone marrow continuously divide. Liver's regeneration after partial hepatectomy. Liver has unlimited division potential. Which category of cells are the hepatocytes? Labile, stable, permanent? They are the stable cells. That is, they divide under stress or injurious stimulus. They are stable cells. Put a star on this. Next example of physiological is action of hormones of growth factors and hormone responsive organs, that is endometrium. In hormone responsive organs, that is endometrial hyperplasia, which is seen normally or physiologically in the usual menstrual cycle. Versus pathological is again, the first example is endometrial hyperplasia. This is not the normal endometrial hyperplasia. This is atypical endometrial hyperplasia, which predisposes to endometrial carcinoma. Endometrial carcinoma. that is endometrial hyperplasia. Next example is BPH, benign prostatic hyperplasia, and the last is skin warts, that is by viral infections like HPV. This is hyperplasia. Next is atrophy. Atrophy, this is reduction in number and size of cells. So again, it can be physiological or pathological. Physiological atrophy, it is seen normally during embryogenesis, that is notochord and thyroglossal duct during fetal development. Next example of physiological atrophy is uterus after parturition, uterus after pregnancy. Next example of physiological is thymus at puberty. Thymus at puberty. All this is physiological atrophy versus pathological atrophy. Pathological, which is disuse atrophy. What is disuse? What did we not use? Because of fractures or long-term immobilization, the skeletal muscle undergoes atrophy, disuse atrophy. Denervation atrophy, the nerve supply has been cut either because of trauma or surgery. Denervation atrophy. Senile atrophy, please note senile atrophy is pathological. It occurs because of ischemia. Which are the main organs undergoing senile atrophy? Brain and heart. Brain and heart. Next, protein energy malnutrition, inadequate nutrition, loss of endocrine stimulation, and pressure atrophy. Lastly, loss of endocrine stimulation, and lastly, pressure atrophy. What is causing pressure on the organs? Tumors. Which tumors would be associated with pressure atrophy? Benign tumors or malignant? Benign tumors. Benign tumors. Why? Because malignant tumors will have more tendency to infiltrate. So malignancies infiltrate, benign tumors enlarge locally, and it is associated with pressure atrophy. Next, the next adaptation is metaplasia. Metaplasia is one lining changing to another. You know that. Now I can divide metaplasia into two types. That is epithelial metaplasia and connective tissue metaplasia. Epithelial and connective tissue metaplasia. First point, epithelial metaplasia is further of two types. That is squamous metaplasia and intestinal metaplasia. And intestinal is a better word than columnar metaplasia. Intestinal is a better word than columnar. Metaplasia means one lining changing to another. Squamous metaplasia means the normal lining changes to squamous. The word before metaplasia is the end lining. Which is more common, epithelial or connective tissue? More common, epithelial metaplasia. Which is more common, squamous intestinal? Squamous metaplasia. More common, squamous. And the classical example of squamous metaplasia is it is seen in respiratory tract in smokers. The normal pseudostratified ciliated epithelium is converted to squamous because of smoking. Other examples of squamous metaplasia are cervix. It is seen in cervix. Next, it is also seen in ducts of breast, salivary glands, and pancreas. Ducts of breast, salivary glands, and pancreas. That is squamous metaplasia. Versus, I'm sure you already know this, intestinal or columnar metaplasia, the classical example of which is Barrett's esophagus. It is Barrett's esophagus. What is the main risk factor for Barrett's? GRD, gastroesophageal reflux disease. Main risk factor, GRD, gastroesophageal reflux disease. Next point, Barrett's, it is pre-malignant. That is, it can progress to malignancy. It is pre-malignant for adenocarcinoma esophagus. It is pre-malignant for adenocarcinoma esophagus. Adenocarcinoma esophagus. This is columnar metaplasia. And the last is connective tissue metaplasia, the classical example of which is myositis ossificans. Classical example of which is myositis ossificans. These are the types of metaplasia. Next point. So these are the four cellular adaptations: hypertrophy, hyperplasia, atrophy, and metaplasia. if the cell is able to adapt, fair enough. Otherwise, it undergoes cell injury. Cell injury was of two types: reversible and irreversible. Starting with reversible cell injury, the earliest change seen in reversible cell injury is cellular swelling. Earliest change seen in reversible cell injury is cellular swelling. What do we mean by this? If this is the plasma membrane with the microvilli, cellular swelling, entry of water occurs, which in turn leads to blibbing, which leads to blibbing, blunting, blibbing, blunting, and loss of microvilli, which leads to blibbing, blunting, and loss of microvilli. Next point. It is also associated with detachment of ribosomes. All these are reversible cell injury. Detachment of ribosomes and swelling of endoplasmic reticulum. Detachment of ribosomes and swelling of endoplasmic reticulum. Next point. Put a star. It is associated with accumulation of small amorphous densities. It shows the presence of small amorphous densities in mitochondria. So please note, if it is a small amorphous density, it is reversible. Versus if it is a large amorphous density, it is irreversible. So small is reversible, large is irreversible. Suppose only amorphous density is written, small or large is not written. What will you mark? Irreversible. Why? Because amorphous density can be large also. So these were the microscopic features of reversible cell injury. Next point. This gets us to the other side, that is irreversible cell injury. First point, you already know this. The first change or the first organelle affected is mitochondria. Which shows the presence of large amorphous densities, which is associated with the presence of large amorphous densities in mitochondria. Next point. Next change seen in irreversible cell injury. Next are the nuclear changes. That is irreversible cell injury. It is associated with pyknosis, compaction of the nucleus, pyknosis, karyolexis, that is fragmentation of the nucleus, and karyolysis. Pyknosis, karyolexis, and karyolysis. Karyolysis is dissolution of the nucleus. Nuclear changes: pyknosis, karyolexis, and karyolysis. And lastly, irreversible cell injury. Nucleus is normally glue in a cell. Because the nucleus is undergoing fragmentation and is dissolving, so basophilia reduces, and eosinophilia increases. In irreversible cell injury, basophilia reduces and eosinophilia increases. This is irreversible cell injury. Next point. Now, irreversible cell injury is of two types: necrosis and apoptosis. I need not even say this, that necrosis is associated with inflammation. So leakage of cellular contents is associated in necrosis. It is associated with leakage of cellular contents. Next point, plasma membrane integrity is lost. All these points are related to each other. Inflammation is seen, plasma membrane integrity is lost, so leakage of cellular contents is seen. Next point, it is only pathological. In nature. Opposite of this is apoptosis. In apoptosis, let me read it here only. In apoptosis, there is no inflammation. Leakage of cellular contents is not seen. Plasma membrane integrity is maintained, and it is both physiological and pathological. You know this. Next point. Apoptosis is of course programmed, caspase-dependent cell death. Necrosis is non-programmed in nature. It is random or non-programmed in nature. So this gets us to patterns of necrosis. Let us first start with necrosis. This gets us to the patterns of necrosis. First point, starting with the first and the most common pattern of necrosis, that is coagulative necrosis. This is the most common type. Associated with ischemia of all organs. It is seen with ischemia except CNS. Ischemia of all organs of the body is coagulative necrosis except ischemia of CNS, which is associated with liquefactive necrosis. Next point, a special subtype of coagulative necrosis is Zenker's degeneration. It is true coagulative necrosis. It is a special subtype affecting muscles. Which muscle? Skeletal muscle is more commonly affected than cardiac. It is seen during acute infections, that is typhoid. And which skeletal muscle is the most strongly affected? Of the abdomen, that is the rectus sheath and diaphragm. The skeletal muscles affected are rectus sheath. And diaphragm. This was coagulative necrosis. Next, as you know, is liquefactive necrosis. Liquefactive necrosis is associated with bacterial or fungal infections. It is associated with bacterial or fungal infections, and is also associated with ischemia of CNS. You know this. Ischemia of CNS, liquefactive necrosis. Next type of necrosis is gangrene. Gangrene is a non-specific clinical term. So it is of two types: dry gangrene and wet gangrene. Wet gangrene is liquefactive necrosis. Dry gangrene is coagulative necrosis. Wet means pus has formed. Pus forms an infection. So wet gangrene is liquefactive. Dry gangrene is coagulative necrosis. Next type of necrosis is gaseous necrosis, associated with tuberculosis. Nothing main point. TB shows the presence of cheese-like material, and it also is associated with granuloma. Gaseous necrosis. Next, extremely important. Next pattern of necrosis is fibrinoid necrosis. Put a double star and write down the diseases associated with fibrinoid necrosis. They are RHD, which in this list is asked. RHD, rheumatic heart disease. PAN, that is polyarteritis nodosa. It is a medium vessel vasculitis. PAN. Now, PAN has two phases: acute phase and chronic. Which phase would be associated with fibrinoid necrosis? PAN, acute phase. How do I know this? Because fibrinoid necrosis is more aggressive in nature. PAN, acute phase. Next, it is also associated with malignant hypertension. Please note, it is malignant hypertension, not benign. Fibrinoid necrosis is more aggressive in nature. Next, SLE, systemic lupus erythematosus. SLE, both. SLE affecting the kidney, that is lupus nephritis. lupus nephritis, and SLE affecting the heart, that is lip and sag endocarditis, lupus nephritis and lip and sag endocarditis. And lastly, it is also associated with graft rejection. Graft rejection. Now, graft rejection, you know from general path immunity that it is of three types: hyperacute, acute, and chronic. Which type of graft rejection is associated with fibrinoid necrosis? Hyperacute, acute, or chronic. Which is the most aggressive in nature? Hyperacute type. Most aggressive, hyperacute graft rejection. These are the causes of fibrinoid necrosis. And lastly, the last pattern of necrosis is fat necrosis. Fat necrosis is obviously associated with fat destruction. Long lipases, they split triglycerides to form esters, which combine with calcium to form chalky white areas. This is called as saponification of fat. And fat necrosis will be seen in areas which has abundance of fatty tissue, that is injury to breast, abdomen, buttocks. Next, it is also seen in peritoneum and is associated with acute pancreatitis. This was fat necrosis. So these were the patterns of necrosis. Next point. There were two patterns of intercell injury or irreversible cell injury: necrosis, apoptosis. Now, before I go to apoptosis, let us have a look at few images. What do you see here? Organ disease, organ, kidney, which shows the presence of a wedge-shaped infarct. Diagnosis, coagulative necrosis. I'm very curious. It is a wedge-shaped, well-defined infarct. What is the site of ischemia here? 1 or 2. What is the site of ischemia? Is it at the apex of the infarct or base of the infarct? Ischemia is present at apex of the infarct. This is the vessel which thrombosed, leading to formation of a wedge-shaped necrotic area. Next, spotter, parent organ, brain, showing the presence of liquefactive necrosis. Brain showing liquefactive necrosis. Next, again a spotter, parent tissue, lungs, which is associated with formation of cheesy white material, that is caseous necrosis. Next, organ, looks like peritoneum, with formation of chalky white deposits, that is multiple sites of calcifications due to saponification of fat. Diagnosis, fat necrosis. So these were the patterns of necrosis. Next, last and an important image, diagnosis. Let us first start with the structure. Blood vessel. How do I know? It is a luminous structure with presence of RBCs in the lumen, showing disintegration of vessel wall. Vessel wall is broken. Disintegration of vessel wall with fibrin-like material. So diagnosis, fibrinoid necrosis. These are the various types of necrosis. Next point. This gets us to the other side, that is apoptosis. Now, starting with apoptosis, it can occur by two pathways. That is the intrinsic or the mitochondrial pathway, and the next is the extrinsic, also called as Fas-ligand pathway. Extrinsic or the Fas-ligand pathway. First point, which is the major pathway for apoptosis? Intrinsic, extrinsic. Major pathway is the intrinsic pathway, that is the mitochondrial pathway, which is associated with leakage of cytochrome C. From the mitochondria. Versus the extrinsic pathway, which is associated with or mediated by CD95. First point. Next, extremely important point, caspases associated with apoptosis. The caspases associated. I can again divide this table into intrinsic and the extrinsic pathway, and the caspases as initiator caspases. That is, they start apoptosis, initiator caspases, and the executioner caspases. Initiator and execution. First point, the initiator caspase of intrinsic pathway is caspase 9, whereas of extrinsic are caspase 8 and 10. Easy to remember. When I have a party at home, I'm the only one present at home. Two friends come from outside. It is a party at my place, so I will sit in the middle. Caspase 9 is initiator caspase of intrinsic, 8 and 10 are of the extrinsic pathway. Next, in the party, everybody will have the same food, so executioner caspases are caspase 3 and 6. Next point, which is the main initiator caspase of extrinsic pathway? 8 and 10. If you have to mark one, caspase 8. Which is the main executioner caspase? Caspase 3. Next point. This gets us to the proteins associated with apoptosis. Again, an important table. I can divide the proteins into anti-apoptotic, pro-apoptotic, and sensors. Firstly, any protein with an element, BCL2, BCLXL, MCL1, FLIP, any protein with an element is anti-apoptotic. Versus BAX, SMAC Diablo. I know pretty fancy name for protein. BAX, SMAC Diablo, pro-apoptotic. Sensors are bad, build, Puma, and Noxa. Sensors regulate the balance between the two groups, but in your exam, if only anti and pro-apoptotic proteins are asked, you can combine sensors with pro-apoptotic proteins also. Firstly. Second point, FLIP was an anti-apoptotic protein which acts only on the extrinsic pathway of apoptosis. It acts only on the extrinsic pathway, not on the intrinsic one. This takes care of necrosis and apoptosis. Next point, before we go further, diagnosis. What do you see here? Be advised, you are able to see the presence of large cells with abundant granular cytoplasm, with a large central nucleus. All these are the hepatocytes, making the parent organ as liver. Now, which cell is abnormal? This one. It is a contracted hepatocyte. Apoptosis of hepatocytes, called as, councilman bodies. Apoptosis of hepatocytes, called as councilman bodies. That much. This takes care of irreversible cell injury, necrosis, and apoptosis. Next point. This starts us with our miscellaneous topics in cell engineering. That is, let us first start with the pigments. Now, before we go further, I can divide the pigments. Into two categories. That is, endogenous pigments or exogenous pigments. I can divide the pigments into two main types: endogenous and exogenous. Most common exogenous pigment is carbon. We live in a very polluted environment. So what is solution? Carbon. Whereas there are three main endogenous pigments, which are lipofuscin, and hemocitrin. Lipofuscin, melanin, and hemocitrin. So starting with our first endogenous pigment, lipofuscin. It is the wear and tear pigment of the body. Firstly, is associated with aging. So it is a telltale sign of free radical injury. Is associated with aging, protein energy, malnutrition, and cancer cachexia. Next point, microscopically, it is yellow brown in color. So when it gets deposited in the heart, it is called as brown atrophy of the heart. When it is getting deposited in the heart, it is called as brown atrophy of the heart. It is yellow brown in color. And lastly, the stain used, Zealand stain. We stain it for a longer time. That is long Zealand stain, lipofuscin. Next endogenous pigment is melanin. Melanin is non-hematite. Hemocitrin is hematite. Melanin is non-hematite. Normally seen in hair, skin, iris. Here it is present in hair follicles. It is seen in hair follicles, skin, iris of the eye. Next, it is also present in stria vascularis of inner ear. You have to remember this. And locus ceruleus, and substantia nigra of the brain. Hair, skin, iris of the eye. Skin, hair follicles, skin, iris. That was obvious. The lower three had to be remembered: stria vascularis of inner ear, locus ceruleus, and substantia nigra of the brain. Next point, put a double star. Stain used for melanin. We use the Mason-Fontana stain. Lastly, IHC, immunohistochemistry. Melanin, it is HMB45 and S100 positive. HMB45 and S100. Which is more specific for melanin? HMB45. More specific for melanin, HMB45. And the last endogenous pigment is hemocitrin. It is seen at sites of local hemorrhage. And the stain used, put a double star. This is the most important point in the whole slide. Stain used is Pearl stain, also called as Prussian blue stain. Stain for hemocitrin, pearls or the Prussian blue stain. Now, this takes care of the pigments. And this finishes our first main topic, first easy topic in general pathology, that is cell engineering. Next, this starts us with our next main topic in general pathology, that is inflammation. First point, starting with basics. That is, let us start with the components of inflammation. Inflammation has three main components: vasodilation, followed by increased permeability of the vessel wall, increased vascular permeability, which leads to emigration of leukocytes from the circulation. Leukocytes come out of the circulation. First easy question: emigration of leukocytes from the circulation is called as diabetes. It is called as diabetes, which is mediated by CD31 or PCAM. PCAM stands for platelet endothelial cell adhesion molecule. Mediated by CD31 or PCAM. Next point. What is the first change seen in blood vessels? First change seen in blood vessels is vasoconstriction. Which is transient in nature. That is, it is for a small time. Transient in nature, followed by vasodilation. Next point. Next is increased permeability. So this gets us to mechanisms of increased permeability. Increased vascular permeability occurs by three mechanisms. It can be immediate transient, that is permeability increase immediately for a short time. Immediate transient, immediate prolonged, and delayed prolonged. First point, which is the most common mechanism? 1, 2, 3. Most common, immediate transient. Brought about by endothelial contraction. Main mediator involved, histamine. And the most common vessel affected. Arterioles, capillaries, venules, and veins. Most common vessel affected, venules. It is the post-capillary venules. Sometimes the student fall into this trap and give me the answer as capillaries. It is the venules. Next mechanism of increased permeability is immediate prolonged, which occurs because of burns or endothelial damage. Because of bacterial or viral products. That is immediate prolonged. And last is delayed prolonged, which occurs because of sunburns, late appearing sunburns, and radiation injury. So these are the mechanisms of increased vascular permeability. Next point. This gets us to the next step. That is, let us have a look at the various steps of inflammation. And their mediators associated. Firstly, but you very well know the various steps: margination, rolling, that is, it is rolling on the vessel wall; adhesion, that is permanent attachment; diabetes, it comes out of the vessel wall; chemotaxis, recognition of the microbe; phagocytosis, and killing. These are the steps. Starting with rolling. Rolling will occur when an endothelial receptor binds with a leukocyte receptor. So a receptor on leukocytes is binding with a receptor on endothelial cells. Let us make the master table of the same: leukocyte receptor versus endothelial receptor. Leukocyte receptor and endothelial receptor. Starting with rolling. The leukocyte receptor for rolling is sialyl Lewis 6 glycoprotein, which binds to selectins present on endothelial cells. Next point, when rolling is taking place, it converts low affinity integrins to high affinity integrins. As a result, permanent attachment, that is, adhesion occurs because of binding of high affinity integrins present on leukocytes with integrin ligands present on endothelial cells. This is rolling and adhesion, the mediators. Next point, selectants. Let us have a look at this here only. Selectants are of three types: P selectants, E selectants, and L selectants. Selectants are of three types. P selectants are present on platelets and endothelial cells. E selectants are on endothelial cells. L selectants are on leukocytes. Let me read it for you. They are on platelets and endothelial cells. Platelets and endothelial cells. E selectants are on endothelial cells versus L selectants, which are on leukocytes. Which is the hallmark of inflammation? 1, 2, 3. E selectant, E selectant, L selectant. Hallmark. E selectant. But what was selected? It was the endothelial receptor for ruling. So hallmark of inflammation, E selectant. Hallmark of inflammation, E selectant. Next point. Defect in CLI Leukocytes glycoprotein. Defect in CLI Leukocytes glycoprotein leads to a defect in ruling. The name of the disease associated with the defect in CLI Leukocytes glycoprotein is LAD1. Leukocyte addition defect. My mistake. It is LAD2. That is leukocyte addition defect. Leukocyte addition defect to LAD2 versus a defect in addition because of a defect in beta 2 integrin. Because of a defect in beta 2 integrin is called as LAD1. Leukocyte addition defect 1. It is called as LAD1. So I can safely say rolling occurs before addition, but LAD2 is a defect in rolling, whereas LAD1 is a defect in addition. Next point. This gets us to our next set of important mediators, that is chemotactic agents. This gets us to our next set, that is after addition, the next step is diabetes. Leukocyte comes out of the vessel wall. We have seen that diabetes is mediated by CD31 of PCAM. After diabetes is chemotaxis. I can divide chemotactic agents into two types: endogenous and exogenous. Exogenous chemotactic agents are the bacterial or viral products. Main point is endogenous chemotactic agents, which are C5a, complement factor 5a, leukotriene B4, LTB4, interleukin 1, interleukin 8, and TNF alpha, tumor necrosis factor alpha. An important list, especially with respect to C5a. Do not confuse C5a with C3a, C3b, C5b. No. Endogenous chemotactic agent C5a. First question, 1, 2, 3, 4, 5. Most potent endogenous chemotactic agent, leukotriene B4. Most potent, leukotriene B4. Complement factor which is most potent, C5a. Next point, what is the role of interleukin 1? It is the most potent pyrogen, that is, it causes fever, followed by, which is the next most potent pyrogen, followed by interleukin 6. Next point, interleukin 8 plays a main role in ARDS, acute respiratory distress syndrome, ARDS, whereas TNF alpha plays a role in sepsis, tumor necrosis factor alpha plays a role in sepsis. These are the chemotactic agents. Next point, after reaching the site of inflammation, leukocyte has to recognize the microbe, which is helped by opsonization agents. Opsonization agents. These are the substances which help in making the bacteria tasty for phagocytosis. Opsonization agents. They make the bacteria tasty for phagocytosis. And which are the opsonization agents? They are C3b. Please note, it is not 3A, 5A, 5B, C3b. Next, FC fragment of IgG. You know very well from microbiology, IgG, immunoglobulin G, has a fragment antigen binding and an FC fragment. FC fragment of IgG. Next, mannose. What makes the bacteria tasty for phagocytosis? Mannose, CRP, C-reactive protein, and fibrinogen. These are the opsonization agents. Next point. After opsonization, there is phagocytosis, followed by killing. Killing occurs by three main pathways. That is the NADPH oxidase pathway, also called as phagocyte oxidase pathway. NADPH oxidase or the phagocyte oxidase pathway. Next, nitric oxide synthase pathway, and the last is lysosomal enzymes. So killing occurs by three pathways. Which is the major pathway? NADPH oxidase pathway. Which are the free radicals generated in NADPH oxidase pathway? They are the superoxide anion, O2 minus, and hypochlorous anion. Next point. Which is the free radical generated by nitric oxide synthase pathway? OMO minus, that is peroxynitrite anion. Peroxynitrite, that is nitric oxide synthase pathway. And the last is lysosomal enzymes. Next point, nitric oxide synthase, NOS pathway. The enzyme nitric oxide synthase is of three types. Endothelial nitric oxide synthase, neuronal nitric oxide synthase, and inducible nitric oxide synthase. Endothelial, neuronal nitric oxide synthase, and inducible nitric oxide synthase. Which plays a role in inflammation? The name tells you. Inducible is the one which is getting induced in inflammation. Endothelial maintains vessel tone. You know that nitric oxide is a vasodilator. It maintains vessel tone, versus neuronal, which acts as a neurotransmitter. These were the names or the pathways of killing. Last point. This gets us to giant cells. Now, before we wrap up this session up, I want to discuss few images with respect to the giant cells. Firstly, there are four fancy named giant cells. What is a giant cell? Cell with multiple nuclei. What you are able to see here is the presence of nuclei at the periphery, giving it the classical horseshoe-shaped appearance. That is diagnosis: Langhans giant cell. Next, diagnosis. What you see here is a giant cell. This is a cell with multiple nuclei, giant cell with abundant foamy cytoplasm. All this white, abundant abundant foamy cytoplasm. This was the cell with presence of abundant foamy cytoplasm. Diagnosis, Taunton giant cell. The fancy name of this giant cell is Taunton giant cell, seen in xanthogranulomatous reactions. Xanthogranulomatous reactions. Taunton giant cell. And the next is it is a large binucleate cell. It has two nuclei, large binucleate cell with prominent eosinophilic nuclei, giving it the classical owl-eye appearance. RS cells, Reed Sternberg cells, RS cells, seen in Hodgkin's lymphoma. Next point, just as a basic question, RS cells, they are positive for which markers? They are CD15 and CD30 positive. We will see the variations of this when we have a look at hematology. Classical RS cell, CD15 and CD30 positive. And lastly, diagnosis. Now, what you see here is the presence of giant cells. All these are the giant cells with multiple nuclei. These are the giant cells in which nuclei are arranged at periphery, giving it the classical horseshoe-shaped appearance. Langerhans giant cell with presence of central necrosis. This is caseous necrosis in the center. Diagnosis, tuberculosis. This was the classical slide of T. Last point. The giant cell seen in measles. I'm writing this below here only. The fancy name of the giant cell seen in measles. It is called as Walton-Finkelday giant cell. This again was important. Walton-Finkelday giant cell. Giant cell seen in measles. Done. So this takes care of our first session, that is cell injury and inflammation. Okay, friends, so this gets us to our next session in the pathology crash course, and two important topics in this session. First are the miscellaneous topics. In pathology, there are three miscellaneous topics, that is the stains, fixatives, and the types of collagen. Starting with the first one, that is stains used in pathology. Starting with the stains. First is for calcium. For calcium, we have two stains. The most commonly used is the von Kosa stain, which all these are factual points, you have to remember them. Most common is the von Kosa stain versus most specific, that is erythritidis. Next point, iron. For iron, we use the Prussian blue, also called as pearl stain. Iron, Prussian blue, or the pearl stain. Next, melanin. For melanin, we earlier also saw this in chapter cell injury, that we use the Mason-Fontana, which is a type of silver stain. Next, for bile pigments, we use modified Fauchet stain. For bile, we use modified Fauchet stain. Next, for copper, there are two stains. First is Orcine, and the second is modified rhodamine stain. Copper, there are two stains, Orcine and modified rhodamine stain. Next point. Next is the most commonly used stain in pathology. Most commonly used stain overall is HND. You know that very well. Hematoxylin and eosin. Hematoxylin is blue in color versus eosin, which is pink. You know that also. Next, for collagen, we use the trichome stains. That is MT, Mason's trichome stain. For collagen, we use the Mason's trichome stain. Mason's trichome. Versus elastin. Easy to remember. After V, E is coming. Verhoff von Giesen stain. Option will be there in front of you. Verhoff von Giesen. After V, E was coming. Verhoff von Giesen stain. Elastin. Next, for reticulin, I'm not much interested in the Luna stain. For reticulin, we use the silver methylamine stain. Silver methylamine reticulin, also called as the SM, silver methylamine stain. And next is fat. I can divide fat into two types, fresh and fixed. For fresh specimen, we use oil redo. Fresh is the frozen section. Versus for fixed fat, we use soda black. Next is for glycogen, we use periodic acid shift. For glycogen, we use PAS, that is periodic acid shift. Another way of asking the same question is periodic acid shift. PAS, it stains glycogen in the liver. In liver, it stains glycogen. Next point, in hematology, it is also used for staining lymphoblasts. Lymphoblasts are block positive with PAS. Next point, in kidney, it stains the basement membrane, mesangial matrix. It stains basement membrane, mesangial matrix, tubular epithelium, and Bowman's capsule. Bowman's capsule. These are the structures stained by PAS, that is periodic acid shift. Next point, Alcian blue. This is again important. Alcian blue differentiates acidic from neutral mucopolysaccharides. Acidic mucins or acidic mucopolysaccharides are Alcian blue positive. Next is for amyloid. You know this very well. Most characteristic stain used for amyloid, Congo red. Next point, what is the color of amyloid with Congo red? With Congo red, it has a salmon red or brick red color. That is amyloid. Please note, it is the apple green birefringence under polarized light. Next point, hematological stains. Firstly, the routinely used hematological stains, that is Giemsa staining, Leishman's right and the Jenner stain. These are the routinely used. Next, myeloid cells are myeloperoxidase, that is MPO, and Sudan black B positive, SBB positive, versus monocytic cells, which are NSE, non-specific esterase positive. We will have a look at the same thing when we will have a look at oncohematology. Next, acid phosphatase is positive in T lymphocytes. Acid phosphatase, PAS, block positivity with PAS in lymphoid cells. We just saw that also, lymphoblasts, PAS positive. Next, photo double star, TRAP, tartrate resistant acid phosphatase, TRAP, is positive in Hades cell leukemia, TRAP positive. Tartrate resistant acid phosphatase, TRAP positive. And last is tolerating blue, used for mast cells. Very, very important. Mast cells and basophils, tolerating blue. Done. This was your first miscellaneous topic, that is stains used in pathology. Next, coming to the fixatives. The most commonly used fixative is 10% formaldehyde. For electron microscopy, most commonly used is glutaraldehyde. But we can also use osmium tetroxide. Next, the fixatives for special tissues. These two were common. Next is fixatives for special tissues. For GI biopsies, gastrointestinal biopsies, Boyne solution. Bone marrow biopsies, zincus fluid. Brain tissue, ammonium bromide. Adrenal medulla, pars fluid. Adrenal medulla, pars fluid. Lastly, let us add one more for pap smears. For pap smears, easy to remember. Alcohol pap smear. That is for pap smears. We use 95% ethyl alcohol. For pap smears, we use 95% ethyl alcohol. These are the fixatives used in pathology. And lastly, coming to the types of collagen. This gets us to the last miscellaneous topic in pathology: types of collagen. Firstly, type 1 collagen. It is the most common collagen in the body. Present in skin, bone, cornea, and endomysium of myofibrils. Skin, bone, cornea, endomysium of myofibrils. Next, as it is present in the bone, it has the maximum tensile strength. Next point, type 2 collagen, present in cartilage, and vitreous humerofine. So bone is type 1, cartilage type 2 collagen. Next, type 3 collagen. Again, it is asked granulation tissue. Now, point to be noted here is as granulation tissue progresses to scarring, type 3 collagen is replaced by type 1 collagen. Scarring is more firm in nature. Which has the maximum tensile strength? Type 1 collagen. Next, type 4 collagen, basement membrane and islands. And last is type 5 collagen, placenta. Easy to remember. Whatever you do in life, don't have more than 5 affairs. Type 5 collagen, placenta. So these were the 3 miscellaneous topics of pathology: stains, fixatives, and types of collagen. Next point. So this starts us with genetics. Now I can divide the genetic disorders into 4 main categories. That is the single gene disorders, which is the Mendelian inheritance, autosomal dominant, autosomal recessive, X-linked recessive, and X-linked dominant, the single gene disorders. Next, very important, the non-Mendelian inheritance, that is genomic imprinting, trinucleotide repeats, mitochondrial inheritance, and gonadal mosaicism. Mosaic means 2 types of chromosomes or 2 types of gene mutation, chromosomal patterns are present in the same individual. The individual is a mosaic, gonadal mosaicism. Next is multifactorial inheritance. Multifactorial inheritance means that environmental factors also play a role, like in diabetes, cleft lip, cleft palate, and congenital heart diseases. Multifactorial inheritance. Simple, straightforward question. Cleft lip, cleft palate, diabetes, and congenital heart diseases. And last is chromosomal abnormalities, which can either be in number or structure. These are the 4 main categories of genetic disorders. Starting with the first one, that is autosomal dominant. All the nervous disorders, that is tuberous sclerosis, neurofibromatosis, autosomal dominant. Which neurofibromatosis? 1 or 2? Both. Next, colon cancers. Which ones? FAP, familial adenomatous polyposis, FAP. HNPCC, hereditary non-polyposis colon cancer, HNPCC. Next, juvenile polyposis syndrome. All the colon cancers, autosomal dominant. Next, hematological disorders. Which hematological disorders are autosomal dominant? They are HS, we write it as capital HS, hereditary spherocytosis, and von Willebrand disease, VWD, von Willebrand disease, autosomal dominant. And lastly, connective tissue disorders, that is Marfan's syndrome, autosomal dominant. These are the main categories of autosomal dominant disorders, the main ones. Next point, let us have a slight more detailed look at Marfan's. Just the salient features. You very well know Marfan's, the patient is very tall, with long extremities, long tapering fingers, that is critical abnormalities are present. Next point, you already know it is autosomal dominant. Marfan associated with abnormalities in chromosome 15. Gene mutation associated, FBN1 gene mutation. Protein, fibrillin 1. Easy to remember. Marfan, chromosome 15, FBN1 gene mutation, fibrillin 1. Next point, Marfan syndrome, let's have a look at the main MCQs. Clinically is associated with ectopia lentis. Ectopia lentis means the eye lens is not in the center, it is dislocated. Which side? Upwards and downwards. It is associated with supratemporal dislocation of eye lens. Next point, Marfan syndrome. It is also associated with serious abnormalities, and one of the most common causes of death in Marfan syndrome is it is associated with aortic dissection. Marfan syndrome is associated with aortic dissections. This is Marfan's. Next point. The next autosomal dominant disorder from which questions are asked is neurofibromatosis. Both 1 and 2 are autosomal dominant. NF1, also called as Van Reckling-Hussen disorder, is associated with mutations in neurofibromin present on chromosome 17, versus NF2, mutations in myelin present on chromosome 22. Next point, NF1. It is associated with neurofibromas, axillary freckling, cephaloid spots, lesion nodules. Not concerned. All I'm concerned with 2 main points. That is the most common tumor seen in NF1 is optic glioma, whereas the most common blood cancer associated with NF1 is JMML, juvenile myelomonocytic leukemia. 2 main points. Most common tumor, optic glioma. Most common blood cancer, JMML, juvenile myelomonocytic leukemia. Next, versus NF2, which is associated with schwannomas and meningiomas. This was autosomal dominant. Next is autosomal recessive. All the metabolic disorders, that is alpha-1 antitrypsin deficiency, cystic fibrosis. Next, Wilson's disease, hemochromatosis, phenylketonuria, L-captonuria. All these L-captonuria, all these metabolic disorders are autosomal recessive. Next category of autosomal recessive disorders are the hematological disorders. Which ones? Sickle cell anemia, thalassemia, both the hemoglobinopathies, autosomal recessive. Next, albinism. For the child to be fair, both the parents have to be fair. Albinism, autosomal recessive. Next is autosomal recessive childhood polycystic kidney disease, childhood PKD. Please note, adult polycystic kidney disease is autosomal dominant, childhood polycystic kidney disease is autosomal recessive. So if only polycystic kidney disease is asked, you will mark it as autosomal dominant. I'll get it for you. Polycystic kidney disease. Let me write it on the side here. Fifth is polycystic kidney disease. Adult PKD is autosomal dominant. Childhood PKD is autosomal recessive. So if only PKD is written, you will mark it as autosomal dominant in nature. Next is X-linked recessive disorders. Next is X-linked recessive disorders. X-linked recessive disorders. They are G6PD deficiency, glucose 6-phosphate dehydrogenase, G6PD deficiency. Next is hemophilia A and B, which occur because of deficiency of coagulation factors 8 and 9. Because of deficiency of coagulation factors 8 and 9. X-linked recessive. Next is X-linked recessive. Next is color blindness. Easy to remember. We are colorblind in nature. X-linked recessive inheritance. Next, chronic granulomatous disease. CGD. Chronic granulomatous disease. X-linked recessive. It is a disease of innate immunity. Chronic granulomatous disease, which occurs because of a defect in NADPH oxidase pathway of killing. Which occurs because of a defect in NADPH oxidase pathway. Chronic granulomatous disease. And the next X-linked recessive disorder. Next is Duchenne's muscular dystrophy. Duchenne's muscular dystrophy. These are X-linked recessive in nature. And the last Mendelian inheritance is X-linked dominant. Last is X-linked dominant, which are Alport syndrome. Next, hypophosphatemic rickets. Alport syndrome. Next, hypophosphatemic rickets. Also called as vitamin D resistant rickets. Hypophosphatemic rickets or vitamin D resistant rickets. Next is Charcot-Marie-Tooth disease. Nobody ever will ask you the details of these, just to complete the list. Charcot-Marie-Tooth disease. And lastly, Rett syndrome. These are X-linked dominant in nature. Now, another question that is asked from Alport syndrome is Alport's. This is an X-linked dominant disorder of the kidney, which occurs because of mutation in alpha 5 chain of the GBM. This occurs because of a mutation in alpha 5 chain of glomerular basal membrane. GBM has which type of collagen? Its most common collagen basal membrane is type 4. So it is also written as Col4A5. Mutation in alpha 5 chain of collagen type 4. That is Alport syndrome. This was Mendelian inheritance. Next point. This gets us to non-Mendelian inheritance. Two main points in this. Let us start with genomic imprinting. Now, genomic imprinting, it is of two types. Maternal imprinting, the gene which is getting imprinted is not getting expressed. Maternal imprinting, and the other is paternal imprinting. Maternal versus paternal. The name of the disease with maternal imprinting is Prader-Willi syndrome. Paternal imprinting is Angelman. Easy to remember. P and P do not go together. In both of these, which is the chromosome involved? It is the long arm of chromosome 15q. Very, very important. Next, there are two ways to have the disease. The first method to have the disease is deletions. Prader-Willi syndrome, Prader-Willi occurs. It was maternal imprinting, that is the chromosome of the mother is physically present, but it does not express itself. Maternal imprinting plus paternal deletion. This is Prader-Willi. Versus Angelman syndrome, which is paternal imprinting plus maternal deletion. So the first method of having a disease is deletions, which accounts for 70% of the cases. Next, the next method of having a disease is disomy. Disomy means both the chromosomes come from the same parent. So in Prader-Willi syndrome, it was maternal imprinting. The chromosome of the mother is physically present but does not express itself. So it is associated with maternal disomy. Versus Angelman, that is paternal disomy. And lastly, the clinical features. Starting with Prader-Willi. If the mother is sleeping, we sit in front of TV and order food whole day. So short stature, we are not going out to play basketball. Short stature, hypotonia, hyperphagia, obesity, hypogonadism, and mental retardation. This is Prader-Willi syndrome. Versus Angelman syndrome. If the father is sleeping, we talk happily on phone all day. So the classical term that is used is happy puppets. That is, it is associated with inappropriate laughter, with ataxic seizures, and is also associated with mental retardation. This is genomic imprinting, Prader-Willi versus Angelman syndrome, one of the high yielding tables. Lastly, this gets us to the list of mitochondrial diseases. I need not even say that mitochondrial inheritance is maternal in nature. You know that. The most common disease with mitochondrial inheritance is MELAS. Mitochondrial encephalopathy, lactic acidosis, stroke-like symptoms, MELAS. Other diseases are Leigh disease or NAR, neurogenic ataxia, retinitis pigmentosa, Leigh disease or NAR. Next, CPO, chronic progressive external ophthalmoplegia, CPO. Next, LHON. All these are the questions. LHON, Leber's hereditary optic neuropathy. KSS, Kearns-Sayre syndrome. Throughout your whole undergraduation, you will never study these diseases anywhere except with mitochondrial inheritance. Pearson syndrome, that is pancreatic insufficiency, pancytopenia, lactic acidosis. And the last is MRF, myoclonic epilepsy, ragged red fibers, and dementia. This takes care of our salient features with genetics. Needless to say, best to start. Cells of the immune system. Firstly, with immunity and starting with the first point in this, that is cells of the immune system. Let us start with cells of the immune system. Firstly, the first cell of the immune system are the T cells. You very well know that T cells, they are of two main types, that is the CD4 positive versus the CD8 positive T cells. CD4 positive T cells, these are the helper T cells, which are MHC 1 year 2 restricted, which are MHC 2 restricted, versus CD8 positive, which are the cytotoxic T cells, and they are MHC 1 restricted. These are MHC 1 restricted. Easy to remember, 4 into 2 is 8, 8 into 1 is 8. So 4 positive MHC 2 restricted, 8 positive MHC 1 restricted. Next point, coming to the T cell receptors. Coming to the T cell receptors. Again, there are two main kinds of T cell receptors. That is the alpha beta T cell receptor and the gamma delta T cell receptor. Which is more common? Alpha beta, gamma delta? Alpha beta, which accounts for approximately 95% of all cases. So the question that is asked is that these 5% gamma delta T cells, where are they present? They are present. They are present where antigen comes in contact with the body. They are present where antigen comes in. Antigen comes in contact with the body. That is mucosa of GIT. That is mucosa of GIT, mucosa of GIT, oral cavity and genitourinary tract, mucosa of GIT, oral cavity and genitourinary tract, genitourinary tract. These are the gamma delta T cells. Next point. This gets us to the types of T helper cell responses. Types of T helper cell, types of T helper cell responses. Now I can divide the T helper cell responses into three main categories. That is the Th1, Th2 and Th17 response, 1, 2 and 17. If you just know that Th2 response is associated with type 1 hypersensitivity versus Th1 response which is associated with type 4 hypersensitivity, which if you know this, you will know everything about types of T helper cell responses. How? Let me show you the master table of the same. It will be slightly faster that way. Let us start with Th2 response. I just told you that it is associated with type 1 hypersensitivity. So which are the cytokines associated with type 1 hypersensitivity? Let's start with Th2 response. Helper cell responses. How? Let me response which is associated with type 4 hypersensitivity, which if you know this, you will know everything about types of T helper cell responses. How? Let me show you the master table of the same. It will be slightly faster that way. Let us start with Th2 response. I just told you that it is associated with type 1 hypersensitivity. So which are the cytokines associated with type 1 hypersensitivity? They are interleukin 4, 5 and 13. Which is the most potent activator of eosinophils? Interleukin 5. Most potent activator of eosinophils, interleukin 5. Next, which is the main immunoglobulin in type 1 hypersensitivity? IgE. And the main cells being mast cells and eosinophils. If both are given in the options, you will mark it as mast cells. Mast cells. Next point, stain used for mast cells. Let me add it here only. Stain used for mast cells, toluidine blue. Stain used, toluidine blue. Next point, Th2 response is associated with type 1 hypersensitivity. So it is seen in allergic reactions, asthma. It is seen in allergic reactions, asthma and parasitic infections. This is Th2 response versus Th1 response, which is associated with type 4 hypersensitivity. So the main cytokines, these are the chronic cytokines, that is interleukin 12 and interferon gamma. Let us add one more here. Interleukin 2 also plays a role in Th1 response. Interleukin 2, interleukin 12, interferon gamma. Main cell macrophages and T cells. But if you have to mark one, you will mark it as macrophages. Next, most common immunoglobulin associated, IgG. Next, diseases associated, autoimmune diseases, IBD, inflammatory bowel disease, IBD, psoriasis, and chronic inflammation, that is granulomas. This is Th1 response. Now, point to be seen here is the same diseases also play a role in Th17 response. In the Th17 response, which are the diseases are not important. What is important is cytokines. It is activated by interleukin 17 and 22. Easy to remember, Th17, interleukin 17 and interleukin 22. Next, plays a role in activation of predominantly neutrophils. So main cell associated neutrophils. These are the types of T helper cell responses. This table was important. Next point. So the first cell of the immune system is the T cell. The next cell of the immune system is the NK cells. First point, NK cells. How do we know these are the natural killer cells? The NK cells are the natural killer cells. They express which markers? NK cells, put a double star, are CD16 positive and CD56 positive. CD16 is the FC gamma receptor. CD16 is the FC gamma receptor versus CD56, which is called as NCAM, neural cell adhesion molecule, called as NCAM, neural cell, also called as NK cell adhesion molecule. It is almost the same thing. Next point, NK cells, they are MHC non-restricted. Repeatedly asked. MHC non-restricted means they do not need MHC for activation. T cells were MHC restricted versus NK cells MHC non-restricted. Next point, they act as the first line of defense. They act as the first line of host defense, and they act against virus infected cells and tumor cells. They act against virus infected cells and tumor cells. These are the NK cells. Next point, CD16, put a star. CD16 plays a role in ADCC, that is antibody dependent cell cytotoxicity. It is the CD16 type which plays a role in ADCC, antibody dependent cell cytotoxicity. It plays a role in ADCC. This was NK cells. The next cell of the immune system are the macrophages. Macrophages, firstly, starting with macrophage activation. I can divide macrophage activation into two types. The classically activated macrophages and the alternatively activated macrophages. Classically activated, these are pro-inflammatory in nature versus alternatively activated, which are anti-inflammatory in nature. So first point, let us first start with classically activated macrophages. Firstly, they are classically activated, so they will play a role in which hypersensitivity? Macrophages play a role in cell-mediated or the delayed type, that is type 4 hypersensitivity. That is the cell-mediated or the delayed type of hypersensitivity. So the main cytokines associated with classically activated are interleukin 2, interleukin 12, and interferon gamma. That is the chronic cytokines. Versus alternatively activated, these are anti-inflammatory. There are three main anti-inflammatory cytokines. That is interleukin 10, TGF beta, transforming growth factor beta, and lipoxins. I'm not writing lipoxins here because it is an arachidonic acid metabolite. So macrophages classically are not negatively activated. Next point. Coming to the fancy names of macrophages in different organs. Starting with kidney. Kidney, macrophages in kidney, they are called as mesangial cells. Next, I need not even ask you, liver, they are called as Puffer cells. Next, blood, macrophages in blood, monocytes. Macrophages in blood, monocytes. Next, macrophages in brain are called as microglia. Macrophages in brain, microglia. These four were obvious. Everybody knew them. What you have to remember is macrophages in spleen are called as littoral cells. Littoral cells. And last is macrophages in placenta, which are called as Hofmeyr cells. Macrophages in placenta, which are the Hofmeyr. Easy to remember. We are afraid of pregnancy. Often will lose the lagna. So Hofmeyr cells. Just a way to remember, but this is how this you have to know this. So these are the cells of the immune system. Next point. This gets us to the next cell of the immune system, that is ABCs, the antigen presenting cells. Very, very important. ABCs, the antigen presenting cells. Antigen presenting cells. Now, again, I can divide ABCs. This is an important flowchart into two categories. That is the professional antigen presenting cells. That is the professional ABCs versus the non-professional ABCs. Professional versus non-professional ABCs. Professional ABCs, they express MHC2. They express MHC2 versus non-professional. Non-professional ABCs, these are the usual nucleated cells. So they express MHC1. We will be studying about MHC as our next topic after finishing off ABCs. So professional express MHC2 versus non-professional. They are the nucleated cells. All nucleated cells express MHC1. Next point. There are three main professional ABCs, which are dendritic cells, macrophages, dendritic cells, macrophages, and B cells. There are three main professional antigen presenting cells, out of which the most potent professional ABC is the dendritic cell. Firstly. Secondly, I need not even say this. All the points that we are doing in this module are either the questions which have been asked in the previous 3 to 4 years or are prospective questions. You have to know this, okay? So dendritic cells, they are the most potent professional ABCs. Firstly. Secondly, dendritic cell of the skin has a fancy name to it called as Langerhans cell. Dendritic cell of the skin is called as Langerhans cell. Please note it is Langerhans, not Langhans. Langhans is a giant cell of the TV. Next, this gets us to the other side, that is non-professional ABCs. There are 6 main non-professional ABCs. Let me project it for you so that it will be faster. There are 6 main non-professional ABCs, which are fibroblasts, thymic epithelial cells, thyroid epithelial cells, glial cells, pancreatic beta cells, and vascular endothelial cells. But you have to remember this list, the non-professional ABCs: fibroblasts, thymic epithelial cells, thyroid epithelial cells, glial cells, pancreatic beta cells, and vascular endothelial cells. These are the antigen presenting cells. Next point. This gets us to the next extremely important concept in immunity, that is MHC, major histocompatibility complex. MHC, also called as HLA, that is human leukocyte antigen. MHC or HLA. Firstly, they are present on chromosome. Put a double star. Chromosome 6. Short arm, long arm, short arm. P for petite. That is short arm of chromosome 6. Next, what is the main role of MHC? The main role is to process and present the antigen. Process and present the antigen to T cells. Main role of APC: process and present the antigen to the T cells. Next point. Does it have to process few antigens or numerous? It has to process numerous antigens. That is, it is highly polymorphic in nature. Because it has to process numerous antigens, it is highly polymorphic. It is of 3 types: MHC 1, 2, and 3. Let us first make a table of MHC type 1 versus type 2. First point. MHC type 1 is present on all nucleated cells and platelets. It is type 2. First point. MHC type 1 is present on all nucleated cells and platelets. It is expressed on, that is a better word, it is expressed on all nucleated cells. It is expressed on all nucleated cells and platelets. Versus MHC 2, which is present only on the professional antigen presenting cells. MHC type 2, which is on professional APC. Next point. Genes associated. All these genes, they are present on short arm of chromosome 6. MHC 1, it is rank 1, so everything is single digit. That is HLA, A, B, and C. Versus MHC 2, second rank, double digit. The genes associated are HLA, DP, DQ, and TR. That is double digit. DP, DQ, and TR. Next, antigen presenting site. Next point, antigen presenting site. In MHC 1, it is rank 1, so everything is alpha 1, alpha 2. Versus MHC 2, it is rank 2, so alpha 1, beta 1. This is MHC 1 versus MHC 2. Nothing major. Majority of the questions in this come from MHC 3. MHC 3 secretes 4 things. That is, it secretes tyrosine hydroxylase. Next, HSP70, heat shock protein 70, HSP70, complement factors B, H, and I, complement factors B, H, and I, and it is also associated with, so MHC3 secretes four things: tyrosine hydroxylase, HSP70, heat shock protein 70, complement factors B, H, and I, and TNF alpha, tumor necrosis factor alpha. This list is important. So this was MHC 1, 2, and 3. Next, this gets us to diseases associated with MHC. Now, if a particular individual has a particular MHC, the chances of him having a disease increases. So, which MHCs are associated with which diseases? Let me project it for you again. It will be faster this way. So, whether you remember anything else or not, you have to remember ankylosing spondylitis and Ritter syndrome, which is associated with HLA B27. Very, very important. Ankylosing spondylitis, Ritter syndrome, acute uveitis, reactive arthritis, and psoriatic arthropathy, which is this is the whole list. These are the seronegative arthritis. I'm not concerned they are seronegative whatsoever. What I'm concerned with is the first two, that is ankylosing spondylitis and Ritter's, associated with HLA B27. Next, celiac disease. Celiac disease is associated with HLA DQ2/DQ8. Celiac disease. Celiac is gluten sensitive enteropathy. DQ2/DQ8. Next point. Just focus on the main ones. Type 1 diabetes. Isme the point to be noted here is it is type 1 and not type 2. Type 1 diabetes is non-specifically associated with HLA DQ2, DR2, DR3, DR4. So question that is asked is which diabetes? Type 1, associated non-specifically with everything. Next, Behçet syndrome is HLA B51. Behçet syndrome. पूछा जाता है. This again is asked. Behçet HLA B51 versus good pastures, that is HLA DR2. HLA DR2. Thromboangiitis obliterans. Thromboangiitis obliterans. This is also called as Buerger's disease. This is the vasculitis associated with smoking. Vasculitis with strongest association with smoking. Strongest association with smoking. I always remember it as Bombay. Delhi, Bombay, one of the most polluted cities. So Bombay, HLA B5. HLA B5. Thromboangiitis obliterans. The ones I have written in red color, which they are must remember. No doubt about it. Next point, I will just write 1, 2 more for your satisfaction, but not needed. Not needed. Stick to the ones I have written with the red color. Next, good pastures was HLA DR2 versus rheumatoid arthritis, that is HLA DR3. Rheumatoid arthritis, HLA DR3. Sjogren's syndrome, HLA DR4. Sjogren's, HLA DR4. Sufficient. These were the diseases. These were the diseases associated with various MS. Next, HLA DR4. Sufficient. These were the diseases associated with various MS. Next point. This gets us to the next topic in immunity, that is complement pathways. This gets us to complement pathways. Now, you very well know that there are three main complement pathways. The classical complement pathway, which starts from C1, involves C2, C4, goes to C3, C5, and MAC. MAC is membrane attack complex. MAC, that is membrane attack complex. A standard question which is asked is MAC is composed of which complement proteins? It is composed of C5 AB, C5B to C9. Next, the other complement pathways are the alternative complement pathway and Mannose lectin binding pathway. Alternative and Mannose lectin binding pathway. Both of these, they converge directly on C3. Alternative and Mannose lectin binding pathways, they converge on C3. These are the main highlights about complement pathways. So, easy question. Which complement proteins are not involved in alternative pathway? Alternative pathway is converging directly on C3. So, C1, C2, and C4 are not involved. Next, much more important than this are the diseases associated with complement pathways. Diseases with complement pathways. Achha, before we go further, we have already seen the role of different complement proteins. Chemotactic agent, C5A. Opsonization agent, C3B. Anaphylotoxins, C3A, C4A, C5A. Let me write it for you, though we have done this, but this is just a quick recap. Complement protein, which is the most important chemotactic agent, C5A. Opsonization agent was C3B versus anaphylotoxins. Anaphylotoxins, which are C3A, C4A, and C5. Next, this was the role of various complement proteins. Next, much more important than this are the diseases associated with complement pathways. Firstly, the most common defect, is deficiency of C2 versus most severe defect, which is deficiency of C3. Most severe deficiency of C3. Next, early complement protein defects. Early complement protein defects increase the risk of SLE, increase the risk of systemic lupus erythematosus, increase the risk of SLE versus late complement protein defects. That is, late complement protein is MAP, C5B to C9, which increases the risk of, increases the risk of Neisseria and toxoplasmosis. Late complement protein defects increases the risk of Neisseria and toxoplasmosis. Next point, C1 esterase inhibitor deficiency. C1 esterase inhibitor deficiency causes hereditary angioneurotic edema. C1 esterase inhibitor deficiency, hereditary, causes hereditary angioneurotic edema. Hereditary angioneurotic edema. This is a very rare disease, but has been asked 2 or 3 times as MCQs. Hereditary angioneurotic edema. And the last is deficiency of CD55 and CD59. We'll see this in hematology also. RBC disorders, which causes which hemolytic anemia? PNH. That is paroxysmal nocturnal hemoglobinuria. It is associated with PNH. Next point. This gets us to the next topic in immunity, that is hypersensitivity reactions. Now, you very well know that there are 4 main hypersensitivity reactions. 1, 2, 3, 4. Type 1. Let us start with type 1 hypersensitivity. This is the immediate type of, this is the immediate or the allergic response. 2 is antibody mediated. 3 is antigen antibody immune complex. 4 is cell mediated or deleted. These are the types of hypersensitivity reactions. Starting with type 1 hypersensitivity, we have already seen that it is associated with Th2 response. So you know the immunoglobulin IgE, you know cytokines 4, 5, 13, you know most potent activator of eosinophils interleukin 5, you know all that. Point is that I can divide type 1 hypersensitivity into two kinds of reaction, an early reaction and a delayed reaction. I can divide type 1 hypersensitivity into two types, an early reaction and a delayed reaction. Early reaction. In this, antigen exposure is needed. In this, antigen exposure is needed versus delayed reaction, in which continuous antigen exposure is not required. In which continuous antigen exposure is not required. Now, the main point here is the mediators associated with delayed reaction, which is very, very important. Delayed reaction, it has four main mediators, which are interleukin 5, eotaxin, interleukin 5, eotaxin, MBP1, that is major basic protein, MBP1, and eosinophilic cationic protein. Has to be remembered. Interleukin 5, eotaxin, MBP, major basic protein, and eosinophilic cationic protein. These are the mediators of late reaction. Versus anything else is an early reaction. So the mediators of early reaction are histamine. Early reaction. The mediators associated are histamine. Histamine. Enzymes like kinases. Enzymes like kinases and tryptases. Kinases and tryptases. PAF. Platelet activating factor. PAF. Platelet activating factor. All these are the mediators of early reaction. This was type 1 hypersensitivity. Next is type 2 hypersensitivity. Type 2 hypersensitivity is the antibody-mediated hypersensitivity reaction. Antibody-mediated. So I will just write few diseases with antibodies associated with it. Starting with Goodpasture syndrome. Type 2 hypersensitivity. Starting with Goodpasture syndrome. Antibody-associated anti-GPM antibody. Goodpasture's anti-GPM antibody. Next, ITP, which stands for immune thrombocytopenic purpura. ITP. Immune thrombocytopenic purpura. Thrombocytopenia is occurring. The platelet count is reducing. Immune thrombocytopenic purpura, which shows the presence of antibodies against platelets. देखो बच्चे, thrombocytopenia will occur only when there is antibody against platelet. So against which receptors? Against GP1B9 and GP2B3A present on platelets. So ITP, immune thrombocytopenic purpura. Next, AIHA, autoimmune hemolytic anemia. All these are antibody-mediated hypersensitivity. Autoimmune hemolytic anemia, which shows the presence of antibodies against RBC membrane. What is the antigen in RBC membrane? It has antibodies against band 3. Please put a star. Band 3. This is a protein present in RBC membrane. This is a protein. Antibody-mediated hypersensitivity type 2. Next example of type 2 hypersensitivity is mismatched blood transfusion. Suppose somebody was A blood group, you give him B blood group. A blood group patient will have anti-B antibody. So antibody-mediated hypersensitivity. And lastly, antibody-mediated hypersensitivity is also seen in pernicious anemia. Pernicious anemia shows the presence of antibodies against intrinsic factor, in turn leading to the development of megaloblastic anemia. It is associated with development of megaloblastic anemia. Another question that is asked is, and pretty common, which is the most common malignancy, what is the most common site of adenocarcinoma stomach after pernicious anemia? Put a star. After pernicious anemia, adenocarcinoma stomach develops in fundus of the stomach. Please note, it is not in the antropyloric region. You know the parts of the stomach, cardia, fundus, body, antropyloric region. It is not in the antropyloric region, it is in the fundus of the stomach. These are the examples of type 2 hypersensitivity, antibody-mediated hypersensitivity. Next, this gets us to type 3 hypersensitivity. Type 3 is antigen-antibody immune complex reaction. Type 3 hypersensitivity. And the classical disease in type 3 hypersensitivity is serum sickness. You cannot alter it. The classical disease is serum sickness. Whereas the localized experimental reaction is called as Arthur's reaction, which both of these points again they are pretty frequently asked. Next, other diseases with type 3 hypersensitivity are PAN, polyarthritis nodosa. PAN is associated with which hepatitis? It is associated with hepatitis B virus. Again asked, PAN, polyarthritis nodosa. Next, it is also seen in PSGN, post-streptococcal glomerulonephritis, PSGN, and SLE, systemic lupus erythematosus, SLE. Next, this gets us to our last hypersensitivity reaction, that is type 4 hypersensitivity. Type 4 is the cell-mediated or the delayed type of hypersensitivity. Let us quickly have a look at the diseases associated with type 4. First is type 1 diabetes. Therefore, type 4 is cell-mediated, there is a response against an antigen. In type 1 diabetes, the antigen is pancreatic beta cells. There is a response against pancreatic beta cells. Next, multiple sclerosis, where the antigen is, it is an unknown antigen. It is an unknown antigen in myelin sheath protein. Next, rheumatoid arthritis has the antigen in joint synovium. Versus contact dermatitis, where the antigen is poison ivy. It is a shrub growing in the west. When it comes in contact with the skin, that is, it leads to itching and blisters. Contact dermatitis, poison ivy. Last is tuberculin reaction and glioma formation, which occurs because of mycobacterium tuberculosis. These are the hypersensitivity reactions. Next point. This gets us to the last and again a repeatedly asked topic in immunity, that is amyloidosis. Firstly, is deposition of abnormally folded protein. Where is it getting deposited? Intracellular, extracellular, both. It is extracellular. Please note it's not intracellular. It is extracellular deposition of abnormally folded protein. Extracellular deposition of abnormally folded protein. Next point. Next point. Let us have a look at the features. Let us have a look at the features associated with amyloidosis. On light microscopy, firstly, the characteristic stain used is Congo red. Most characteristic stain is Congo red. And on light microscopy, it has the brick red or salmon red color. It shows a brick red or salmon red color. Under polarized light, Congo red shows the classical apple green bidifferentials. That is, apple green color, it shines. It shows apple green bidifferentials under polarized light. So please note if the color of amyloid is used, please don't mark it as apple green. Apple green is under polarized light. Overall, it is brick red or salmon red color. Next, it is yellow with thioflavin T on immunofluorescence. Immunofluorescence with thioflavin T, yellow. Next, on electron microscopy, it shows non-branching fibrils. Easy to remember, they are simple straight lines. It shows non-branching fibrils, which are 7.5 to 10 nanometers in diameter, versus on X-ray crystallography and infrared spectroscopy, it shows the presence of beta-pleated sheets. On X-ray crystallography and infrared spectroscopy, it shows beta-pleated sheets. Next, coming to the classification, it is of three main types: systemic, hereditary, and localized. Which protein is getting deposited? In primary amyloidosis and also in multiple myeloma, the protein is AL, amyloid light chain, versus secondary amyloidosis, where it is AA, which in this slide is very important. AL in primary amyloid light chain versus secondary AA. The most common cause of secondary amyloidosis being rheumatoid arthritis. Most common cause being rheumatoid arthritis. Next, hemodialysis associated amyloidosis is associated with deposition of beta-2 microglobulin. Next, coming to hereditary amyloidosis, there are three main hereditary amyloidosis: familial Mediterranean fever, familial amyloidotic neuropathies, and systemic senile amyloidosis. Familial Mediterranean fever, the protein is AA. So secondary amyloidosis and familial Mediterranean fever is same, AA. Versus in the lower two, where the protein is ATTR, that is transthyretin. Where the protein getting deposited is transthyretin. Now, point to be noted here is, in familial amyloidotic neuropathies, it is mutated form of transthyretin versus systemic senile amyloidosis, where it is the wild type of transthyretin. I'm not concerned with wild and mutated. Keep it simple. In lower two, it is transthyretin. And last is localized amyloidosis. And please note, do not confuse senile cerebral amyloidosis with systemic senile. Systemic senile, the protein was wild type of transthyretin, versus senile cerebral, that is Alzheimer's disease, the protein is A-beta. And last, localized is medullary carcinoma thyroid, where the protein getting deposited is ACAL, that is amyloid calcitonin. ACAL, that is amyloid calcitonin. Done. This finishes immunity. Okay, so friends, this gets us to the next topic in general pathology, and an important one, that is neoplasia. So let us start with slight basics in neoplasia. The absolute general terms you very well know: hamartoma. This is disorganized growth indigenous to the inward side. What do we mean by this? For example, bile ducts are present organized in portal tract and liver. Suppose instead of being organized into portal tracts, they are randomly present. That is a bile duct hamartoma. Example, bile duct hamartoma. These bile ducts are present in disorganized manner in the liver only. Next general term is choriostoma. It is heterotopic rest of normal tissue. Chori करके it has gone to another side. That is example, pancreatic tissue in stomach. That is choriostoma. Next, metaplasia. We saw this in cell injury also. It is replacement of one type of tissue with another. Next point. Now, whenever tumor occurs at a particular site, body tries to contain that tumor by fibrosis. That is called as desmoplasia. This is the response of the body to the tumor. It is abundant collagenous stroma or abundant fibrosis occurring in a tumor. The tumors which are desmoplastic in nature, they will have fibrosis. As a result, grossly, will they be soft or will they be firm and hard? Because of the associated fibrosis, they are firm and hard in nature. Next point. The next general term is dysplasia. Dysplasia means abnormal or disordered growth of cells. It shows nuclear pleomorphism. That is, few nuclei are small, few are very large. Abnormal nuclear morphology with a high nucleocytoplasmic ratio. Nucleocytoplasmic ratio is increased. That is, it has a large nucleus and cytoplasm. What is the normal NC ratio? Normal NC ratio is 1:4 to 1:6. That is, for every one part of nucleus, there is 4 to 6 times cytoplasm. Next, dysplasia has hyperchromasia. It is a dense hyperchromatic black nucleus with increased number of mitotic figures, which are normal, and loss of nuclear polarity. Nuclear polarity means, suppose these are the columnar cells. Normally, the nuclei are present on one side of the cell. This is called as nuclear polarity is maintained. Dysplastic cells, some nuclei are at bottom, some are at the top. That is, they show loss of nuclear polarity. And one of the most important points in dysplasia is it lacks invasiveness. Very, very important. Next point, full thickness dysplasia. Let me write this here only. Next point, full thickness dysplasia. Full thickness dysplasia is called as carcinoma in situ. Full thickness dysplasia is called as carcinoma in situ. What is the difference between carcinoma in situ and carcinomas? Basement membrane is intact. In carcinoma in situ, basement membrane is intact versus carcinomas or malignancies where the basal membrane is breached. Next point. This starts us with our main topic. That is, this is where we actually start with the topic neoplasia, starting with characteristic features of malignancy. First point, which malignancy just wants to grow. So, which is the most characteristic feature? Most characteristic feature of malignancy is metastasis. Most characteristic feature of malignancy, metastasis. Suppose this is not given in the options, followed by capsular invasion. Most characteristic feature, metastasis. If that was not given in the options, followed by second most characteristic feature, capsular invasion. Next, malignancies. They are self-sufficient in growth signals. They are insensitive to growth inhibitory signals. A malignant tumor just wants to grow. So it is self-sufficient and non-responsive to growth inhibitory signals. This is how actually we should also be in our life. We should not respond to the negative things which are happening around us. We should be insensitive to growth inhibitory signals. Next, it is a malignancy. It wants to grow. So apoptosis is reduced. Very obvious, if apoptosis was high, it won't be able to grow. Apoptosis is reduced. Next, malignant cells have an altered cell metabolism called as Warburg effect. We will see this in detail. Next point, they have limitless replicator potential. Why? Because of which enzymatic activity? Because of increased telomerase activity. They have limitless replicator potential because of increased telomerase activity. And next point, malignancy. It is also associated with angiogenesis. That is new blood vessel formation from existing blood vessels. These are the features of malignancy. Next point. Before we go further, let us have a look at few microscopies. You know that there are 2-3 main malignancies: squamous cell carcinoma, adenocarcinoma, anaplastic carcinoma, and so on. Diagnosis. Now, what you see here is gland formation. All these which are glands with gland formation with presence of a central lumen. Gland formation with presence of a central lumen. Next point, all the cells lining the glands, they're dysplastic with loss of nuclear polarity. So diagnosis, adenocarcinoma. Versus, have a look at this one now. The minute I see this, I know it is a malignancy. How do I know that? Because it shows the presence of tumor cells with prominent nuclei. That is, it is a malignancy of squamous origin. This looks squamous. Diagnosis, squamous cell carcinoma. With presence of keratin pearl. You can be asked this with an arrow also. That is diagnosis. It was a keratin pearl with presence of keratin pearls. Next, diagnosis. Now, the minute I see this slide, it is a malignancy. It shows marked nuclear polymorphism. Some nuclei are very small, some are very small, whereas some are very large. Marked nuclear polymorphism. With what is this? This can again be asked with an arrow. Answer. This is a tripolar mitosis. It has 3 arms. That is, it is a tripolar mitosis. It is an abnormal mitosis, tripolar mitosis, giving it the classical Mercedes-Benz sign. Next point, diagnosis. Is it squamous or adeno? Neither bache. It is neither squamous nor adeno. So diagnosis, anaplastic carcinoma. Next point. Let us start with the most characteristic feature of malignancy, that is metastasis. Now, you very well know that carcinomas metastasize through lymphatics. You know this. Versus sarcomas, which metastasize through the hematogenous route. Nobody will ask you this. What are the exceptions? Which carcinoma metastasizes through hematogenous route? There are 2 main ones. Carcinomas with hematogenous spread. They are HCC, that is hepatocellular carcinoma, and renal cell carcinoma, HCC and RCC. Next, why? Because they are very vascular in nature. Versus sarcomas with lymphatic spread. Which in this list has to be remembered. There are 6 sarcomas, which are alveolar rhabdomyosarcoma, angiosarcoma, clear cell sarcoma. Alveolar, angiosarcoma, clear cell sarcoma. Epithelioid sarcoma or epithelial sarcoma is the same thing. Malignant histosarcoma and synovial sarcoma. Have a good look at this. These are the sarcomas with lymphatic spread. Next point. This starts us with our first main table. That is, now you know that malignancies can occur by 2 things. Either it can occur by activation of proton oncogenes or inactivation of tumor suppressor genes. I repeat, if the proton oncogene is activated, it leads to malignancy. If a tumor suppressor gene is inactivated, it leads to malignancy. Let us first start with tumors associated with oncogenes, that is activation of proton oncogenes. Starting with the first one, that is the growth factor receptors, EGFR. All the ones I'm writing for you, very, very important. Because in neoplasia, it has numerous tables and factual information. You have to know this. EGFR is called as ERB1 versus ERB2 is HER2 or Herceptin receptor. It is HER2 or the Herceptin receptor. First point, let us start with EGFR. EGFR or ERB1 is classically associated with adenocarcinoma lung versus Herceptin receptor, which is associated with breast cancer, versus ERB2 or Herceptin, which is with breast cancer. Next, FLT3. FLT3 is seen in acute leukemias. FLT3 is associated with acute leukemias. Next, red proton oncogene mutation. First question, present on chromosome 10, is associated with MEN syndrome. Now, MEN is of 3 types: MEN 1, 2A, and 2B. It is associated with MEN 2, both 2A as well as 2B, both MEN 2A as well as MEN 2B, present on chromosome 10. MEN 1 is caused by a tumor suppressor gene MEN. We will see that in 5 minutes. MEN 2 is caused by red proton oncogene present on chromosome 10. Another point that is asked here is, which thyroid malignancy is associated with MEN 2? Medullary carcinoma thyroid. So you can even be asked this as medullary carcinoma thyroid. Medullary carcinoma thyroid is associated with which proton oncogene mutation? Red, present on chromosome 10. Next point. Next is PDGFRB. PDGFRB associated with gliomas. Is a brain tumor. Next, extremely important, KIT. C-KIT, also called as CD117. C-KIT or CD117, associated with GIST, that is gastrointestinal stromal tumor. Associated with GIST, that is gastrointestinal stromal tumors. It is a stromal tumor, that is, it is a mesenchymal tumor. So I can safely say it is the most common mesenchymal tumor of the abdomen. GIST. Another point that is asked is most common site of GIST, stomach. marker secret or CD117. Next is ALK expression. ALK associated with adenocarcinoma lung, very important, associated with adenocarcinoma lung and anaplastic T cell lymphomas. Adenocarcinoma lung and anaplastic T cell lymphomas. These are the growth factor receptors. Next, continuing the same table, proteins involved in signal transduction. This is the first category of protein proteins was the growth factor receptors. Second is involved in signal transduction, the RAS proteins, KRAS, HRAS, and RAS. KRAS is associated with adenocarcinoma colon. It is associated with adenocarcinoma colon, lung, and pancreas. Colon, lung, and pancreas. Versus HRAS, which is associated with kidney and bladder tumors. NRAS, on the other hand, is associated with melanomas. Next point, I can rephrase this as melanomas involve two main proton genes. First is NRAS, and the next is BRAF mutations. BRAF is also associated with melanoma. It is associated with, very commonly asked, associated with melanomas, a blood cancer, that is hairy cell leukemia, and it is also associated with colonic adenocarcinoma. So BRAF mutation associated with three tumors: melanomas, hairy cell leukemia, and colonic adenocarcinomas. Next point, let us slightly go back. ABL, you know this. BCR ABL, Abelson gene present on chromosome 9. BCR present on chromosome 22. You know this. BCR ABL chromosome 9, 22, Philadelphia chromosome, associated with CML, chronic myeloid leukemia, and it is also seen in BLL. So CML and ABL chromosome 9. Next is Notch1 mutations, again associated with blood cancers, and it is also associated with breast carcinoma. Notch1. Next, before we go further, let us have a look at beta catenin, which is very important. APC, WNT, beta catenin and KRAS. beta catenin and KRAS, extremely important, associated with colonic adenocarcinoma. First point, all four: APC, WNT, beta catenin, KRAS. Next point, beta catenin in particular, let me put a star on this with a different color, is also associated with HCC. It is also associated with hepatocellular carcinoma. Next is JAK2. Coming to the last point in this table, genus kinase 2 domain in this slide. JAK2, genus kinase 2 domain mutations seen in PV. It is a type of blood cancer, polycythemia vera, seen in PV. That is polycythemia vera. Next is the cell cycle regulators. Cyclin D1, again important. Put a star. Mantle cell lymphoma. The ones which the more number of times you see this table, more you will remember. There is absolutely no shortcut to it. Those of you who write stuff and paste it on your wall, now can see the tables are to be pasted on the wall. Next is cyclin E gene mutation associated with breast cancer. Not that important whether you remember cyclin E with breast cancer or not, I'm okay with it. And CDK4, which is again associated with melanomas and glioblastoma. Glioblastoma multiforme or glioblastoma, it is a CNS tumor. Now the only important point with respect to cell cycle regulators was cyclin D1. Next, extremely important, MYC gene mutations. MYC is of three types: CMYC, NMYC, LMYC. Very commonly asked. CMYC mutation associated with Burkitt's lymphoma. Burkitt's lymphoma. NMYC, neuroblastoma versus LMYC, which is associated with small cell carcinoma lung. LMYC, small cell carcinoma lung. These are the gene mutations or mutations of the proton gene mutations associated with various malignancies. We divided them into three main categories: the growth factor receptors, the signal transduction, and cell cycle regulators. The last category was nuclear regulators. The main one in that was MYC. These were the proton genes with tumors associated. First one. Next, this gets us to the next concept, that is cell cycle. You very well know that there are 5 phases: G0, G1, S, G2. You know this. You also know that duplication of DNA takes place in S phase. You know this. Next point, again, there are two main checkpoints in the cell cycle. That is G1S and G2N. Which is the main cell cycle checkpoint? G1S. Main checkpoint, G1S. Both the tumor suppressor genes. There are two main tumor suppressor genes, which are P53 and RBG. Both of these act at G1S. First point. Next point, P53 is also called as molecular policeman. It is also called as molecular policeman or guardian of the genome. Versus RBG, which is governor of the genome. Next point, put a double star. If you are asked new molecular policeman of the genome, molecular policeman was P53. New molecular policeman of the genome is the P10 gene. New molecular policeman, P10. Very important. Next point, chromosomes associated. P53, chromosome 17. If it is a bigger number, smaller. P for petite is the small number. 17, P13 versus RBG, which is present on chromosome 13. 13 is a smaller number, so bigger arm. 13Q is a long arm. 13Q14. Easy to remember. P53, 17, P13, RBG, 13Q14. P10, on the other hand, is present on long arm of chromosome 10. Chromosome 10Q. RP10 gene, chromosome 10Q. Next point. This gets us to, there were two checkpoints: G1S and G2M. How are the checkpoints crossed? The checkpoints, they are crossed by cyclins binding to cyclin-dependent kinases. Let us start making the table from below. Now, cyclin A and cyclin B help in crossing G2M. Cyclin C is not there. Cyclin D and cyclin E. Cyclin C was not there. Cyclin D and cyclin E help in crossing G1S. Next point, cyclins bind to cyclin-dependent kinases. So again, we will start writing from below. CDK21, CDK1. CDK3 is not there. CDK46, CDK46, and CDK2. CDK46 and CDK2. These are the cyclins binding to cyclin-dependent kinases. Next point, which is the main cell cycle checkpoint? G1S. Which is the main cyclin responsible for crossing G1S? Cyclin D. D for Delhi binding to CDK4. Just a way to remember. These are the best possible answers if you have to mark one answer. Next main cyclin for crossing G2M. Cyclin B. So Delhi Bombay, cyclin B binding to CDK1. These are the checkpoints and how they are crossed. Next point. This gets us to our next table, that is mutations associated with or tumors associated with tumor suppressor genes. Starting with the first one, that is APC. APC gene mutation associated with FAP, familial adenomatous polyposis. FAP, that is familial adenomatous polyposis. FAP, present on chromosome 5. Very, very important. Next, coming to the neurofibromatosis. NF is of two types, NF1 and NF2. Both NF1 and NF2 are autosomal dominant in nature. First point. Next point, both are associated with mutations in tumor suppressor gene. NF1 is with neurofibromin, present on chromosome 17, versus NF2, which is with Merlin, present on chromosome 22. Next point, NF1 is associated with neurofibromas. It is associated with neurofibromas and MPNST, malignant peripheral nerve sheath tumors. MPNST, malignant peripheral nerve sheath tumors, versus NF2, which is associated with schwannomas, and meningiomas. Next point, PTCH, put a star, is associated with Golden syndrome. Very, very important. It is associated with Golden syndrome. What is Golden syndrome? It is basal cell carcinoma, which this is an absolute fact. Just has to be remembered as a factual information. It is basal cell carcinoma and medulloblastoma. That is Golden syndrome, PTCH. Next point, P10 gene was the new molecular policeman present on long arm of chromosome 10, chromosome 10q. P10 gene mutation is associated with Cowden syndrome. Again, put a double star. P10 gene mutation associated with Cowden syndrome. What is Cowden syndrome? Let me write it on the side here. Cowden syndrome. It is associated with mutations in tumors in breast, endometrium, and thyroid. It is associated with breast carcinomas, endometrial carcinomas, and thyroid malignancies. That is P10, breast, endometrium, thyroid, Cowden syndrome. Next, SMAD2 and SMAD4 gene mutations. SMAD2 and SMAD4 associated with juvenile polyposis syndrome. Juvenile polyposis syndrome. And last is RB gene mutation. I need not even say anything in this. Which is the most common malignancy with RB gene mutation? Retinoblastoma. Most common is retinoblastoma. Followed by question that is asked us, which is the second most common malignancy with RB gene mutation? Followed by osteosarcoma. This is important. Most common was retinoblastoma, followed by osteosarcoma. Next point. Next set of tumor suppressor genes are the VHL, von Hippel-Lindau syndrome. VHL, von Hippel-Lindau syndrome, present on chromosome 3. All these are the questions which are present on chromosome 3, associated with clear cell RCC, clear cell renal cell carcinoma. VHL, von Hippel-Lindau, RCC, clear cell RCC. Next point, STK11 gene mutation. STK11 associated with Peutz-Jeghers syndrome. You know this very well from GIT. Peutz-Jeghers syndrome is associated with polyps in the intestine with hyperpigmentation around the cavity. Peutz-Jeghers syndrome. Next point, SDHB, succinate dehydrogenase. Succinate dehydrogenase B and T is associated with pheochromocytomas. It is associated with pheochromocytomas. Next point, coming to the much more important ones. Put a double star. E-cadherin gene mutation. Senan, signet ring cell adenocarcinoma. Stomach. And it is also associated with the breast cancer. Which breast cancer? You know there are two main breast cancers, lobular carcinoma and ductal. Which is associated with E-cadherin gene mutation? Lobular carcinoma breast. Next, P53. Almost any tumor of the body we can always fit in P53 gene mutations. Here I'm just interested in one fact, that familial P53 gene mutation, put a star, is called as Li-Fraumeni syndrome. Familial P53 is called as Li-Fraumeni syndrome. So have a recap. P53 Li-Fraumeni syndrome. PTCH was the Golden syndrome. Whereas the other one, the P10 gene mutation. Where did it go? P10 gene mutation, Cowden syndrome. So three syndromes. Just a sec. Let me highlight it for you. PTCH is Golden syndrome. P10 gene mutation, Cowden syndrome. And P53 Li-Fraumeni syndrome. Next point, BRCA1 and BRCA2. Next is BRCA1 and BRCA2. BRCA1 present on chromosome 17, whereas BRCA2 is present on chromosome 13. First point, associated with breast and ovarian cancer. Next, all the gene mutations starting with M, that is MSH2, MSH6, MLH1, all the gene mutations starting with M belong to HNPCC. Hereditary non-polyposis colon cancer. HNPCC. Hereditary non-polyposis colon cancer. So I can safely say colon cancer can occur either after formation of a polyp, that is familial adenomatous polyposis (FAP), which was APC gene mutation, versus HNPCC, non-polyposis colon cancer. The colon cancer occurred without formation of a polyp, which was associated with gene mutations starting with M. Next, Wilms tumor, WT1 gene mutation, Wilms tumor present on chromosome 11, WT1 gene mutation, chromosome 11. And the last point is MEN1, associated with mutation in menin, which is a tumor suppressor gene, again seen on chromosome 11. Please note, MEN2 was associated with ret proto-oncogene present on chromosome 10. MEN1 is associated with mutations in menin, which is a tumor suppressor gene. Next one. So this takes care of the tumors associated with proto-oncogene mutations and tumor suppressor gene mutations. Next point. This gets us to the next topic, that is Warburg effect. You very well know that Warburg effect is altered metabolism. It is altered metabolism of tumor cells, meaning tumor cells, even in presence of oxygen, convert glucose to lactic acid. Tumor cells, even in presence of oxygen, convert glucose to lactic acid. In all of us, lactic acid production is anoxidative. Here it is even in presence of oxygen. Next point. Put a line on the side. Normally, that is in all of us, when lactic acid is produced, how many ATP are synthesized? 2 ATP. Versus in tumor cells, when lactic acid is being produced in presence of oxygen, how many ATP are synthesized? 4 ATP. 4 ATP. First point. Next point. Why do the tumor cells produce lactic acid? Is it for the ATP? No. It is for intermediate metabolites. It is for intermediate metabolites needed for growth of the tumor. Intermediate metabolites needed for growth of the tumor. That is Warburg effect. Next point. What is the significance of Warburg effect? Warburg effect forms the basis of PET scan. It forms the basis of PET scan. Why do we do a PET scan? PET scan, it is performed to detect sites of metastasis. It is performed to detect sites of metastasis. What is the basic principle of PET scan? The basic principle, PET scan, it works on glucose hunger of cancer cells. How? We give 18 FDG to the patient. In this Warburg effect of PET scan, we give 18 FDG. We give 18 FDG to the patient. In this Warburg effect of PET scan, we give 18 FDG, 18 fluorodeoxyglucose. We give 18 fluorodeoxyglucose to the patient. This is a non-metabolizable derivative of glucose. Wherever cancer is present, this tumor cells will take up 18 FDG and they will get lit up. So the basis of PET scan is glucose hunger of cancer cells. Next point. This gets us to the next topic in neoplasia, that is microbial carcinogenesis. Starting with HDL1. HDL1 is associated with T cell lymphomas. Next point. Hepatitis C. I need not even say this. Hepatitis C is an RNA virus. Which hepatitis is the only DNA virus? Hepatitis B. So both hepatitis B and C are associated with HCC, hepatocellular carcinoma. Next, coming to DNA viruses. HPV, human papillomavirus, obviously is associated with squamous cell carcinoma cervix. Next, squamous cell carcinoma esophagus. Next, it is also associated with carcinoma head and neck and carcinoma anal canal. HPV, human papillomavirus. Next is EBV. Again, extremely important. Put a double star. Seen in nasopharyngeal carcinoma, associated with nasopharyngeal carcinoma, Burkitt's lymphoma, and Hodgkin's lymphoma. Another question that is asked is, which is the most common Hodgkin's lymphoma associated with EBV? Most common Hodgkin's with EBV, mixed LRT. Most common Hodgkin's lymphoma with EBV, mixed LRT. Next, hepatitis B, HCC, hepatocellular carcinoma. Next, H. pylori. I need not even say this. It increases the risk of gastric adenocarcinoma, but reduces the risk of esophageal adenocarcinoma. H. pylori. I'll go back to pylori. Next, HHV8, human herpes virus 8, HHV8, associated with Kaposi sarcoma, primary effusion lymphoma, HHV8, Kaposi sarcoma, primary effusion lymphoma, and Castleman disease, HHV8. Next, schistosomiasis, bladder malignancies, squamous cell carcinoma, urinary bladder, and the last is Opisthorcus sinensis, also called as Clonorchus sinensis or Opisthorcus sinensis, associated with cholangiocarcinoma. Cholangiocarcinoma is a malignancy of the biliary tract. So these are the various microbial carcinogenesis. Next point. This gets us to a small but an important topic, tumor lysis syndrome. This occurs because of destruction of large number of rapidly proliferating cancer cells. Now the question that is asked is, it is associated with therapy of Burkitt's lymphoma and ALL, firstly, and because of lysis of tumor cells, it causes hyperuricemia, uric acid increases, hyperkalemia, potassium increases, phosphate increases, hyperphosphatemia, calcium reduces, put a double star, hypocalcemia. This is asked, which is pretty commonly asked. Calcium reduces, hypocalcemia, and acidosis. This is tumor lysis syndrome. Next point. This gets us to the tumor markers or the immunohistochemistries associated with various malignancies. Carcinomas are cytokeratin positive versus sarcomas, which are pimentin positive. Firstly, next, S100 and HMB45 is associated with melanoma. Out of these, which is more specific for melanoma? HMB45. More specific. HMB45. Next point, LCA, that is leukocyte common antigen, also called as CD45, is positive in lymphomas. Next point, Desmin, put a double star. This again is important. It is positive in alveolar rhabdomyosarcoma. Next and the last point with respect to immunohistochemistry is GFAP, glyphibillary acetate protein, GFAP, which is positive in gliomas. They are the brain tumors. Lastly, this takes us to the last topic in neoplasia, that is tumor markers. Tumor markers, they are used for screening of cancers. Next point, they help in monitoring of survivors after treatment and help in diagnosis of specific tumor types, but they are not used for confirmatory diagnosis. Why? Because the same tumor marker, let us assume AFP, it is elevated in HCC, hepatocellular carcinoma, and is also elevated in York sac tumor ovary. So it is not used for confirmatory diagnosis. Next point, so let us have a look at important tumor markers, starting with HCG, human chorionic gonadotropin, elevated in trophoblastic tumors. Diagnosis. Next point, so let us have a look at important tumor markers, starting with HCG, human tumor ovary. Was the same tumor marker, let us assume AFP, it is elevated in HCC, hepatocellular carcinoma, and is also elevated in York sac tumor ovary. So it is not used for confirmatory diagnosis. Next point, so let us have a look at important tumor markers, starting with HCG, human chorionic gonadotropin, elevated in trophoblastic tumors, non-seminated testicular tumors, which ones? Choriocarcinoma. Important है, choriocarcinoma. Next point, calcitonin, medullary carcinoma thyroid. It is elevated in medullary carcinoma thyroid. Catecholaminé metabolites, elevated in pheochromocytoma. I'm just comfortable with the word pheochromocytoma. Catecholaminé metabolites, pheochromocytoma. AFP, we have already seen liver cancer, that is HCC, hepatocellular carcinoma, and York sac tumor ovary. Next, CEA, carcinoembryonic antigen. CEA, it is a non-specific tumor marker. It is non-specific in nature and is elevated in adenocarcinomas of the colon, pancreas, lung, stomach, and breast. So it is elevated in almost all the adenocarcinomas. Next, gastrin, ZD syndrome, Zolliger-Ellison syndrome is associated with hypergastrinemia. Next, have a look at the CA markers. CA 125, ovarian cancer. 19.9, colon and pancreatic cancer. Next, CA 15.3. I always remember it as 15 years breast development. 15.3, breast cancer. CA 15.3, breast cancer. And lastly, CA 72.4. I remember it as for 72 rupees you get the ice cream. 72.4, gastric cancer. Lastly, beta-2 microglobulin is elevated in multiple myeloma, and increased levels of beta-2 microglobulin in multiple myeloma is associated with poor prognosis. Increased levels of beta-2 microglobulin in multiple myeloma is associated with poor prognosis. These were the tumor markers, and which this totally finishes neoplasia. So this starts us with our second session, that is hematology. We are already done with general pathology, and this starts us with hematology. Hemat is divided into two main parts, that is oncohematology or blood cancers, one of the toughest topics in pathology, and non-oncohemat. Non-oncohemat takes care of RBC disorders and bleeding disorders. So let us start with oncohematology. First point, we will be stressing on three main types of blood cancer: acute leukemias, CML, chronic myeloid leukemia, will show to you, and lymphomas. So leukemias and lymphomas. Starting with the first one, that is acute leukemias. Now, firstly, what do we mean by acute leukemia? It shows the presence of blasts more than or equal to 20%, where either in peripheral blood or bone marrow. This is what we mean by acute leukemia. Next point, it is of two main types. Blasts are of two main types, that is lymphoblasts or myeloblasts. Lymphoblasts are seen in ALL versus myeloblasts, which are seen in AML. So our first thing is how will we differentiate between the two. Firstly, let us start with versus myeloblasts, which are seen in AML. So our first thing is how will we differentiate between the two. Firstly, let us start with myeloblast. What is the microscopic characteristic feature of a myeloblast? It shows the presence of odd rods. If I'm able to see an odd rod, I'm sure it is a myeloblast. Next, myeloblasts have moderate amount of cytoplasm. They have some cytoplasm. They have moderate amount of cytoplasm. अगर थोड़ा सा cytoplasm है, so cytoplasmic granules are present and it has multiple nuclei. Cytoplasmic granules are present and it has multiple nuclei. Versus lymphoblasts, which has a scant amount of cytoplasm. Cytoplasm is very less. Cytoplasmic granules are absent, and so are the nuclei. This is the microscopic difference between lymphoblast and a myeloblast. Next point. Before we go further, let us have a look at what it looks like. Now, I know this is the first slide of my PPT on hematology, but Martin Luther King Jr. told us that I have a dream. Strong words. Repeat these words often, and I know very less time to go before your paper, but give it your best shot. Repeat this often and keep on going further. You will get through. So, firstly, starting with the first slide, this is peripheral smear. How do I know that? It shows the presence of RBCs in the background. All these are the RBCs with large cells. They are large cells, moderate cytoplasm with cytoplasmic granules. Moderate cytoplasm with cytoplasmic granules. All these are the cytoplasmic granules. That is, these are myeloblasts. Or they are more than 20%. All are myeloblasts only. So diagnosis AML. Next, have a look at this cell now. This is again a large cell, 2.5 to 3 times the size of an RBC with presence of an all rod. Look at these two elongated structures. They are all rods. That is myeloblasts. So all myeloblasts will not show the presence of all rods. These are the softer features of a myeloblast. Moderate cytoplasm, cytoplasmic granules. Versus, have a look at this slide. Again, very large cells, 2.5 to 3 times the size of an RBC. This is an RBC. As compared to an RBC, we are 2.5 to 3 times the size of an RBC with scant cytoplasm. Cytoplasm is very less, no granules. That is, these are the lymphoblasts. These are the lymphoblasts seen in ALL, acute lymphoblastic leukemia. So myeloblast versus lymphoblast. The first way to differentiate between the two is microscopy. Next, but microscopy will not always be helpful, so we need better techniques. The next way to differentiate between the two is cytochemistry. Next is cytochemistry. Lymphoblasts are PAS positive. They show block positivity with PAS, periodic acid shift. They show block positivity with PAS. Versus myeloblasts, which show positivity for myeloperoxidase. They are MPO positive. That is myeloperoxidase positive and Sudan black B positive. They are myeloperoxidase and Sudan black B positive. Next point, a subtype of myeloblast is monoblast. A subtype is monoblast. Monoblasts, they are NSE positive. That is, they are non-specific esterase. They are NSE. That is non-specific esterase positive. Next, lymphoblasts are of two types: B lymphoblast and T lymphoblast. T lymphoblast, that is TALL, is TDT positive. TDT stands for terminal deoxytransferase. It is TDT, terminal deoxytransferase positive. This is ALL, or two types of blasts, or let me rephrase this as myeloblast versus lymphoblast. Next point. This starts us with the first main ALL, that is DLL. This is much more common than TLL. Firstly, it accounts for approximately 80 to 85% cases of ALL. First point. Next main question that comes from BLL is the good versus poor prognostic markers. This table is important for BLL. Good prognosis versus poor prognostic markers. First point. I need not even tell you that lymphadenopathy, lymph node involvement, liver spleen involvement, hepatosplenomegaly, lymphadenopathy, increased TLC, increased blast percentage. These are poor prognostic markers. That was obvious. Next point. ALL, it is seen in children. Extremes of ages, that is, age less than 1 year or more than 10 years is poor prognosis versus intermediate age group, 1 to 10 years is good prognosis. Next one is poor prognosis, males and females. Males have a poor prognosis because of the associated testicular involvement. So testicular involvement is a separate, independent poor prognostic marker. Next, CNS involvement is again poor prognosis. Now, what I wrote till this point, they were commonsensical. They are not asked. What are asked is continue the same table of good and poor prognosis, molecular markers. The first poor prognostic molecular marker of BALL is translocation 922, which is extremely important. Translocation 922 is seen in CNL and also in BALL. What is the fusion transcript? BCR-ABL. Which subtype is seen in BALL? P190. Very important. You already know that BCR is present on chromosome 22 versus ABL, which is present on chromosome 9. Next, other poor prognostic markers in BALL are translocation 411 and hypodiploidy, which is poor prognosis, versus hyperdiploidy and translocation 1221, which are good prognosis. Translocation 1221, fusion transcript, tell AML. Tell the patient he has AML, but it is a good prognostic BALL. These are the molecular markers associated with BALL. This was important. This takes care of ALL. Next, coming to the other side, that is AML, acute myeloid leukemia, starting with FAB classification, French American British classification of AML. Firstly, most common AML, M2. Least common AML, M7. M7 is also called as acute megakaryocytic leukemia. M7, acute megakaryocytic leukemia. How, if it is least common, I will not diagnose it till I am sure it is M7. So which are the markers present in M7? It is CD41 positive, CD61 positive, 41, 61. Next, MPO negative AML, M0, M6 and M7. M6 is also called as acute erythroleukemia. M6, acute erythroleukemia. How do we know it is erythroleukemia? Which markers are positive? It is CD36 and CD71 positive. So 41, 61, M7, 36, 71, M6. Whether you remember M6 markers or not, I'm okay, but MPO negative AML, M0, M6, M7. This was important. Next, extremely important, best prognostic AML. Best prognostic, you have to know this, is M3. also called as acute promyelocytic leukemia. M3, acute promyelocytic leukemia. First point, most common translocation in M3. We are writing all these points below M3. Most common translocation in M3, translocation 1570. Fusion transcript. Whenever translocation occurs, it leads to formation of a fusion transcript. PML rara. Fusion transcript, PML rara. More number of times you repeat, more you will remember. Why is it best prognosis? Because we have therapy against it, that is ATRA, or trans retinoic acid. We have therapy against it, that is ATRA, or trans retinoic acid, ATRA. Next point, most common cause of death in M3 is DIC, disseminated intravascular coagulation, DIC. So I can safely rephrase this as DIC is most common in which AML? It is most common in M3. Last point, most common leukemia associated with Down syndrome. Downs you very well know is trisomy 21. We saw that in genetics. Most common leukemia in Downs. Answer ALL, acute lymphoblastic leukemia, versus the most common AML in Downs. So differentiate between the two questions. Most common AML in Downs is AML M7. That is acute megakaryocytic leukemia. So the least common AML is the most common AML in Downs. This takes care of the acute leukemias, ALL and AML. Next, this gets us to the next entity, that is Hodgkin's lymphoma. This starts us with Hodgkin's lymphoma. Now, the most commonly used classification of Hodgkin's is the WHO classification, which divides Hodgkin's lymphoma into two main categories. That is the classical Hodgkin's, that is the classical and lymphocyte predominant Hodgkin's lymphoma. Classical and lymphocyte predominant Hodgkin's, which is important. Classical Hodgkin's is further of four types, that is mixed cell Hodgkin's lymphoma, mixed cell nodular sclerosis, lymphocyte rich Hodgkin's lymphoma, and lymphocyte depleted Hodgkin's. So classical is of four types: mixed cell nodular sclerosis, lymphocyte rich, and lymphocyte depleted. The other side is lymphocyte predominant Hodgkin's. First point, most common Hodgkin's in India, mixed cell. It is easy to remember. We are a secular country, make sure of everybody. Most common in India, mixed cell. Most common in West, nodular sclerosis. Best prognostic Hodgkin's, lymphocyte predominant. Best prognostic, lymphocyte predominant. Versus worst prognostic, lymphocyte depleted. Easy to remember, more the number of lymphocytes, better is the prognosis, depleted, worse prognosis. Next point. Now, two viruses are associated with Hodgkin's. Which ones? HIV and EBV. Epstein-Barr virus and HIV. Both HIV and EBV are most commonly associated with mixed cell. So, most common Hodgkin's with HIV, mixed cell. Most common Hodgkin's with Epstein-Barr virus, mixed cell. Next point. EBV negative Hodgkin's lymphoma. EBV negative Hodgkin's, lymphocyte predominant. All the classical Hodgkin's, all classical Hodgkin's are EBV positive. Most common was mixed cell. EBV negative Hodgkin's is lymphocyte predominant. Next point, Hodgkin's lymphoma. I need not even say this, that it shows the presence of RS cells. RS cells microscopically have the classical owl-like appearance. You know that it is a large binucleate cell, prominent eosinophilic nucleoli. It has owl-like appearance. Next point, RS cells are CD15 positive and CD30 positive, except the RS cells seen in lymphocyte predominant Hodgkin's lymphoma. In lymphocyte predominant Hodgkin's, RS cells are CD15 and 30 negative. Agreed, they are 15, 30 negative. So which markers are they positive for? They are CD20 positive and CD45 positive. Out of this, CD20 positive is very important. So if you have to mark one, they are CD20 positive. Classical RS cell is CD20 and 45 negative. Next point, the RS cell seen in lymphocyte predominant Hodgkin's has a fancy name to it called as POC1 cell, or LNH. That is lymphocyte and histiocytic cell. Lymphocyte and histiocytic cell. This is RS cells. So the first variant of RS cell is lymphocyte predominant Hodgkin's lymphoma, which shows the presence of POC1 cells. And the second variant of RS cells, so first was lymphocyte predominant Hodgkin's, which shows the presence of POC1 cells, and the second variant of RS cells are the lacunar type of RS cells. Lacunar type of RS cells seen in nodular sclerosis, Hodgkin's lymphoma. Lacunar type seen in nodular sclerosis, Hodgkin's lymphoma. These are the variants of RS cells. Last point. This gets us to Burkitt's lymphoma. This gets us to Burkitt's lymphoma. 2-3 points with this. Burkitt's lymphoma. Again, they are asked most common translocation 814. Gene mutation. It is associated with c-MYC gene mutation. Present on chromosome 8. There are three types of MYC: c-MYC, Burkitt's; n-MYC, neuroblastoma; l-MYC, small cell carcinoma lung. This is MYC. Next, coming back to Burkitt's, on lymph node biopsy, Burkitt's shows the classical starry sky appearance. On lymph node, I just showed you, it shows the classical starry sky appearance. Lastly, it is a B cell lymphoma. Next, so before we go further, let us have a look at RS cells, the various subtypes. Now, starting with, or let us have a look at the next image, diagnosis. Now, this is again peripheral smear. It shows the presence of RBCs, peripheral smear, showing large cells with presence of multiple odd rods. Multiple odd rods in a cell. All these are the odd rods which I'm drawing in the cytoplasm. Multiple odd rods in a cell are called as faggot cells. They are called as faggot cells, seen in M3. You already know the remaining points about M3. Next, diagnosis. This which is a spotter. This is a classical RS cell. It is a classical RS cell. It is a large binucleate cell with prominent eosinophilic nuclei, giving it the owl-like appearance. Giving it the owl-like appearance. RS cells. Next, this is the low power. That is 10x view of the same previous cell. This is the same classical RS cell. When the cell itself was telling you that I am an RS cell, this was a high power view. This was 40x versus this one which is 10x classical RS cell. Next, have a look at this one. This is something that we eat while while watching movies. This is the popcorn cell. Seen in lymphocyte predominant Hodgkin's lymphoma. This was the one, popcorn cell. This was the one which was CD15 30 negative, CD20 positive, CD20 positive. Next point, diagnosis. Now, this is again a large binucleate cell with prominent nuclei with clear cytoplasm. That is, it is the lacunar type. There is a clear lacuna in the cytoplasm. This is the lacunar type of RS cells seen in nodular sclerosis, Hodgkin's lymphoma. So I have shown you all three RS cells: classical, popcorn cell, lymphocyte predominant, and the nodular and the lacunar type seen in nodular sclerosis, Hodgkin's lymphoma. Next, diagnosis. Now, this is a peripheral smear. How do I know the presence of RBCs? With large cells as compared to an RBC, showing the presence of cytoplasmic vacuoles. Are you able to make out these vacuoles in the cytoplasm? The minute you see cytoplasmic vacuoles, diagnosis Burkitt's lymphoma. Diagnosis Burkitt's. This was on peripheral smear. Versus, look at the lymph node biopsy of the same. This is the starry sky appearance. Stars are the macrophages. Stars are the macrophages in a sky of Burkitt cells. Starry sky appearance. Where stars are the macrophages. Stars are the macrophages in a sky of Burkitt cells. Stars are the macrophages in a sky of Burkitt cells. That is Burkitt's lymphoma. Done. So this takes care of your first part of metallurgy, that is ongoing. Okay, so hi friends, this gets us to our next topic in hematology, that is RBC disorders. Now, starting with RBC disorders, you very well know the four basic terms, that is MCV, mean corpuscular volume, MCH, that is mean corpuscular hemoglobin, and MCHC, that is mean corpuscular hemoglobin concentration. Next point, what is the difference between MCH and MCHC? Mean cell hemoglobin concentration. So this takes into account volume of the RBC. MCHC takes into account volume of the RBC. It takes into account volume of the RBC. And what are the normal values? Normal MCV is 82 to 96 femtoliters. It is mean cell volume. Volume is in liters. It cannot be 1 or 2 liters. It is in femtoliters. Next, normal MCH is 27 to 33 picograms. That is, this is the mean amount of hemoglobin in mean cell hemoglobin. Whereas mean cell hemoglobin concentration is 33 to 37 grams per deciliter. It is 33 to 37 grams per deciliter. These three basic terms you very well know. Next is RDW. Next basic term is RDW. That is red cell distribution width. RDW. That is red cell distribution width. RDW. Now, this is a measure of, what do we mean by RDW? All of us have the same height, but still there is variation in our height. So similarly, normal sized RBCs will also show some variation in their size. So that is the red cell distribution width, which is a measure of an isocytosis or poikilocytosis. It is a measure of altered size of the RBC. That is, it is a measure of an isocytosis. It is a measure of altered size of the RBC. Next point, altered shape of the RBC is called as poikilocytosis. Easy one-liners. Next point, normal RDW is 11.5 to 14.5%. Next, we have already seen that poikilocytosis. Poikilocytosis is altered shape of the RBC. Poikilocytosis is altered shape of the RBC. Next point, these were the few basic terms with RBCs. So this is where we start with our first main topic, that is reticulocytes. What are reticulocytes? Reticulocytes, they are immature RBCs circulating in peripheral blood. They are the immature RBCs in peripheral blood. So I can safely say that they are an indicator of bone marrow erythropoiesis. Meaning more is the erythropoiesis in the bone marrow, more will be the immature RBCs in peripheral blood. Next point, normal reticulocyte count is 0.5 to 2.5%. Next point, reticulocytes, they are stained by supravital stains. That is, we keep the reticulocytes alive. They are stained by supravital stains, which are the most commonly used is new methylene blue. Most commonly used is new methylene blue. Whereas next we can also use brilliant crescite blue. Most common is new methylene blue, but brilliant crescite blue can also be used. These are the reticulocytes. Next point. This gets us to reticulocyte count. That is, I can divide RBC disorders on the basis of reticulocyte count into low versus high retic count. I can divide them into low versus high retic count. Which are the diseases with low retic count? Low retic count means bone marrow erythropoiesis is reduced. Low retic count, the diseases associated, they are aplastic anemia. What do we mean by aplastic anemia? Aplastic anemia means all the three lineages of the bone marrow, erythroid, myeloid, megakaryocytic, everything is suppressed. Aplastic anemia. Next, which hormone is
is needed for erythropoiesis? Erythropoietin, secreted by kidney. So next disease with a low retic count is chronic kidney disease. Next, myelofibrosis. Very obvious. If the bone marrow is undergoing fibrosis, if the bone marrow is undergoing fibrosis, the space for erythropoiesis is reduced. As a result, they have a low retic count. These three were obvious. What you have to remember is put a double star. Very, very important and repeatedly asked nutritional anemias. Please do not go wrong in this. All nutritional anemias, that is iron deficiency anemia, folic acid deficiency, and vitamin B12 deficiency, have a low retic count. Nutritional anemias and anemia of chronic disease, ACD, anemia of chronic disease. These are the causes of low retic count versus high retic count, which is seen in hemolytic anemias. So the first disease which should come to your mind when anybody talks of high retic count is hemolytic anemia. Next, another cause of high retic count is nutritional anemia on therapy. Another cause is nutritional anemia on therapy. Please see that nutritional anemias had a low retic count. When we give them therapy, that is iron and folic acid is started, nothing is wrong in the bone marrow of the patient. He was just deficient nutritionally. So when it is started, the retic count increases and peaks at day 7 of therapy. This is retic count low versus high. Next point. This starts us with our main topic, that is anemia. This starts us with our main topic in our disorders, that is anemia. So starting with classification of anemia on the basis of size of the RBC. On the basis of size of the RBC, I can divide anemia into three types. That is microcytic hypochromic. Microcytic means the size of the RBC is small. Let me write it completely for you. Microcytic hypochromic. Hypochromia means the central pallor is more than 1/3. You know that normally RBCs have central 1/3 pallor. This is normal, central 1/3 pallor. If it is hypochromic, the central 1/3 pallor is more than 1/3. MCNC. Next is NCNC. Normocytic, normochromic. Size is normal and so is the pallor. And the last is macrocytic. Anemia. First point. Which are the causes of MCHC, microcytic hypochromic? An important table and an obvious one. Most common cause of microcytic hypochromic anemia is iron deficiency anemia. Most common cause is iron deficiency anemia. Next, other causes are thalassemia, sideroblastic anemia, and anemia of chronic disease. Thalassemia, sideroblastic anemia, and anemia of chronic disease. A standard list. These are MCLC. Next is normocytic normochromic. I can divide normocytic normochromic anemia on the basis of retic count. Into low versus high retic count. Causes of low retic count, you know that is aplastic anemia. Low retic count is aplastic anemia. Chronic kidney disease, myelofibrosis. We just made this list. Next cause of low retic count was nutritional anemia. Should I write nutritional anemia normocytic normochromic? No, because iron deficiency anemia is microcytic. Folic acid B12 deficiency is macrocytic. So we will not write nutritional anemias. Next is ACD, anemia of chronic disease, versus high retic count, which is seen in hemolytic anemias. You know this. And the last category is macrocytic anemias. Again, I can divide macrocytic into two types. That is megaloblastic anemia, and non-megaloblastic. Anemias. Megaloblastic is folic acid and vitamin B12 deficiency. This is megaloblastic versus non-megaloblastic anemia, which is associated with liver diseases. So first point, this is the classification of anemia on the basis of size of the RBC. Next, let us see the associated questions with this. Firstly, let us start with MCHC, microcytic hypochromic. You very well know most common cause of anemia, MCHC, iron deficiency anemia. Next question over this flow chart is over. We are writing below this. Next question, most common type of anemia in hospitalized patients. Answer which is all the causes of anemia that we have mentioned in this flow chart are your options. Most common cause of anemia in hospitalized patients is anemia of chronic disease, ACD. It is not iron deficiency anemia because ideally we treat it on OPD basis. We will not admit the patient in a 5,000 per day room for giving a 10 tablet. So ACD, most common type of anemia, ACD. Next point, most common type of anemia seen in ACD. Microcytic hypochromic, normocytic normochromic, and macrocytic. देखो, anemia of chronic disease, it caused both MCHC as well as normocytic normochromic. Which is most common type? MCNC, that is normocytic normochromic. This is more common, whereas ACD rarely is associated with MCHC. But because it is rarely associated, it is a cause of microcytic hypochromic. Done. So first point, all the points written in this slide are important. This is the classification of anemia on the basis of size of the RBC. Next, this gets us to classification of anemia. On the basis of etiology, that is on the basis of cause of anemia. I can divide anemia into three types. That is blood loss. It is associated with blood loss. Next, increased destruction of RBCs. Increased destruction of RBCs, which is called as hemolytic anemias. Hemolytic anemias. And the last is reduced production of RBCs. Reduced production of RBCs. These are the three main causes of anemia on the basis of etiology: blood loss, increased destruction, reduced production. First point, let us start with hemolytic anemias, the classification here only. Firstly, most common RBC membrane defect. Most common RBC membrane defect. Answer check. Usually in my live classes, students sometimes mistakenly say it as G6PD deficiency. No, it is an enzyme deficiency, not membrane. Most common RBC membrane defect, HS, hereditary spherocytosis. Hereditary spherocytosis. That is HS. Completely hereditary spherocytosis. Next point, most common RBC enzyme deficiency. Most common RBC enzyme deficiency is G6PD deficiency, glucose 6-phosphate dehydrogenase, G6PD deficiency. Next is hemoglobinopathies. Hemoglobinopathies. There are two main hemoglobinopathies, which are sickle cell anemia. We can write it as HB small s. Sickle cell anemia and thalassemia. Hemoglobinopathies. Next is PNH. That is paroxysmal nocturnal hemoglobinuria. PNH, paroxysmal nocturnal hemoglobinuria. And the last is AIHA, that is autoimmune hemolytic anemia. AIHA, that is autoimmune hemolytic anemia. These are the hemolytic anemias. Next one. Another question which is asked from this is, firstly, these were the one-liners. Next is what is the inheritance pattern of each? Let us start with HS, hereditary spherocytosis, inheritance. We write it as capital HS. It is autosomal dominant in nature, AD. Next, very important, put a star, G6PD deficiency. Inheritance, X-linked recessive. Next, both the hemoglobinopathies, sickle cell anemia and thalassemia, both the hemoglobinopathies are autosomal recessive. Next, PNH. Answer bachche. PNH, autosomal recessive dominant, X-linked recessive dominant answer. We cannot blame our parents for everything. Both PNH and AIHA are acquired in nature. They do not have a family history. Both of these are acquired in nature. So these are the hemolytic anemias and their classification. Next point, we'll do them. We'll have a look at the salient features of each one by one, not to worry. And last classification of anemia is reduced production of RBCs. If the production of RBCs is reduced, that means it is associated with a reduced retic count. If there is reduced production, the retic count reduces. This is the third time we are making this list here. You know the causes. They are aplastic anemia. Next, chronic kidney disease, myelofibrosis. Aplastic anemia, CKD, chronic kidney disease, myelofibrosis. Next, extremely important, nutritional anemias. They have a low retic count, nutritional anemias, and anemia of chronic disease. So this is the classification on the basis of etiology. Blood loss, increased destruction, and reduced production. Next one. So let us start with our first hemolytic anemia. That is HS, hereditary spherocytosis. Starting with the first one, that is hereditary spherocytosis. First point, you already know hereditary spherocytosis, it is autosomal dominant in nature. You know that. You also know that it is the most common RBC membrane defect. Next point, the most common protein mutated or defective in HS, most common protein defect in RBC membrane seen in HS is the defect in enkidin. Most common is the defect in enkidin versus the most severe defect in HS versus the most severe, which is the defect in alpha spectrum. So have a good look at what the examiner is asking you. Most common defect in HS, enkidin, whereas most severe defect in HS, alpha spectrum. Both of these are the normally found proteins in RBC membrane. Next point, you very well know that an RBC is biconcave in shape. It's a very badly drawn biconcave shape. You know that an RBC normally is biconcave. So another question that is asked is the most common protein or the main protein. Let's rephrase this as main protein responsible for maintaining biconcave shape of the RBC. Main protein responsible for maintaining biconcave shape of the RBC is spectrin. Normally, it is the spectrin protein. Which is responsible for maintaining the biconcave shape of the RBC. That is why most severe defect in HS is associated with abnormalities in alpha spectrum. Next point. Hereditary spherocytosis, HS, microscopically shows the presence of spherocytes. How do we recognize a spherocyte? They lack the central 1/3 pallor. Spherocytes lack the central 1/3 pallor. So this is what a cell of hereditary spherocytosis or HS look like. The spherocytes or RBCs lack the central 1/3 pallor. Next point. Test used for hereditary spherocytosis. Because the RBC is spherocytic, the RBC does not have extra membrane to change the shape. So it is associated with increased osmotic fragility. So very, very important. Even if a small amount of water enters into the RBC undergoes hemolysis. Osmotic fragility is increased in HS. Why so? Because RBCs do not have extra membrane to change their shape. Next point. So increased osmotic fragility. So test use osmotic fragility test. Next point. So another question that is asked is which are the diseases associated with increased osmotic fragility? Increased osmotic fragility occurs. This occurs because of reduced deformability of RBC. RBC is not able to change the shape. Reduced deformability of RBC, which is seen in HS. Why does HS have increased osmotic fragility? Because it is associated with the presence of spherocytes on peripheral smear. Which other disease other than HS also shows the presence of spherocytes? Which other disease also shows the presence of spherocytes? It is AIHA, autoimmune hemolytic anemia. So two diseases with increased osmotic fragility, HS, hereditary spherocytosis, and autoimmune hemolytic anemia, versus reduced osmotic fragility, which is seen in sickle cell anemia. Why? Because in sickle cell anemia, as such, the RBC is dehydrated. So when water enters into the RBC first the RBC becomes normal and then it undergoes hemolysis. Sickle cell anemia, thalassemia, and iron deficiency anemia. Sickle cell anemia, thalassemia, and iron deficiency anemia. This is osmotic fragility testing, increased versus reduced osmotic fragility. Next important point, again put a star. Thalassemia is associated with reduced osmotic fragility. This in thalassemia is employed as Nestrov test. पूछा जाता है. This again is asked. Nestrov test is used for thalassemia. Nestrov stands for naked eye. It stands for naked eye, single tube. Naked eye, single tube, red cell osmotic fragility test. Naked eye, single tube, red cell osmotic fragility test. This is HS, hereditary spherocytosis, and the test used for HS. Next point. This gets us to our next hemolytic anemia, that is G6PD deficiency. Glucose 6-phosphate dehydrogenase, G6PD deficiency. Firstly, G6PD, you know that it is the most common RBC enzyme deficiency. Next, inheritance, it is X-linked recessive in nature. You know that. Next point. In G6PD deficiency, what is the main problem? G6PD deficiency, it is an enzyme of HMP. It is an enzyme of hexose monophosphate pathway. As a result, because of reduced G6PD enzyme, RBCs undergo oxidative damage. Pathogenesis. G6PD deficiency is associated with oxidative damage to globin chains. Oxidative damage to globin chains. As a result of which, globin chains precipitate in RBCs. Leading to the formation of Haynes bodies. Haynes bodies are seen in G6PD deficiency. Next point. Let us assume that this is an RBC with presence of Haynes body. This is what a Haynes body looks like. When it goes to the spleen, this RBC gets bitten off, leading to the formation of white cells. So white cells and Haynes bodies are associated with G6PD deficiency. Next point. G6PD deficiency. Which RBCs undergo hemolysis? Young or old? It is usually the old RBCs which are more prone to hemolysis. And hemolysis is precipitated by drugs. It is precipitated or accentuated by drugs. From pharmacology, we will know antimalarials, pymaclin, sulfaquin, and stuff. They precipitate or they increase the hemolysis associated with G6PD deficiency. Next point. Most common site of hemolysis in G6PD. It can show both. Most common site of hemolysis, G6PD deficiency can show both intravascular as well as extravascular hemolysis. But most common is extravascular hemolysis. In spleen of the patient. This is G6PD deficiency. Next point. This gets us to a next important question, that is hemolytic anemias associated with both intravascular and extravascular hemolysis. Hemolytic anemias associated with both intravascular and extravascular hemolysis. There are three hemolytic anemias which show both intravascular and extravascular. They are first is obviously G6PD deficiency. Next, others are sickle cell anemia, and autoimmune hemolytic anemia, AIH. Sickle cell anemia and autoimmune hemolytic anemia. Now, autoimmune hemolytic anemia is of two types: the warm type of antibody or the cold type, which is associated with both hemolysis. The cold type of AIH. Next point. Both G6PD and sickle cell anemia, more common is extravascular hemolysis in spleen of the patient. In the first two, more common is extravascular hemolysis in spleen, versus in cold type of AIHA, where more common is extravascular hemolysis in liver of the patient. This was G6PD deficiency. Last point. Test used for G6PD deficiency. Test used for G6PD deficiency. We use MRT, that is methemoglobin reduction test. Test used is MRT, that is methemoglobin reduction test. Done. This finishes G6PD deficiency. Next point. This gets us to a next hemolytic anemia, that is sickle cell anemia. This gets us to a next hemolytic anemia, that is sickle cell anemia. First point, sickle cell anemia. You very well know this occurs because of a point mutation. In 6th codon of beta chain. As a result, glutamic acid is replaced by valine. You know this. As a result, glutamic acid is replaced by valine, leading to the formation of HPS. Hemoglobin is HPS polymerized on deoxygenation. You knew that, leading to the formation of sickle cells. What is the problem because of these sickle cells? Clinical features. The first clinical feature is these sickle-shaped RBCs. They get stuck in the vasculature. They have reduced deformability of RBC. They cannot change their shape. They get stuck in the blood vessels, leading to vaso-occlusion. So the first clinical feature is it is associated with vaso-occlusive crisis. Sickle cell anemia, vaso-occlusive crisis. Which are the sites of vaso-occlusion? It is associated with dactylitis. Dactylitis means bone pains. Dactylitis of bones of hands and feet. Dactylitis of the bones of hands and feet. Next, if it is getting stuck in the cerebral vessels, it is associated with stroke. In retinal vessels, it is associated with retinopathy. Next, it is also associated with priapism. What is priapism? Painful erection. This is vaso-occlusive crisis. Next clinical feature is these sickle-shaped RBCs, they get stuck in splenic vasculature. That is splenic changes. Now, because it is occluding the splenic vessel, the earliest change seen in sickle cell anemia in spleen, earliest change is splenic enlargement because of sequestration of RBCs. Earliest change is splenic enlargement, which is followed by multiple splenic infarcts, multiple splenic infarcts, in turn leading to autosplenectomy. Pucha jata hai, this again is asked. So earliest change in spleen and sickle cell anemia is splenic enlargement, followed by autosplenectomy. Next point. So is splenectomy indicated in sickle cell anemia? No, splenectomy is not indicated. Next, the next clinical feature with sickle cell is now autosplenectomy has occurred. What was the role of spleen? It is a graveyard of RBCs, I agree. And secondly, it is also it is a reticular endothelial organ responsible for formation of antibodies. Autosplenectomy increases the risk of infections. Especially by encapsulated organisms. Like, which are the main encapsulated organisms? That is Haemophilus influenzae. And streptomyces. Another question that is asked with respect to infections is most common cause of osteomyelitis in general population. Myelitis is inflammation, osteobone, infection of the bone. In general population is Staph aureus. Most common cause of osteomyelitis in general population is Staph aureus, versus in sickle cell anemia, where the most common cause is salmonella. So the third clinical feature, increased risk of infections. We have seen three. First was vaso-occlusive crisis. Second was splenic changes. Third is increased risk of infections. And the last clinical feature associated with sickle cell anemia is aplastic crisis. This occurs because of infection of erythroid precursors. All the three words are important. Which cells are getting infected? Erythroid. Infection of erythroid precursors. Where are erythroid precursors present? In bone marrow. They are present in the bone marrow. Infection of erythroid precursors in bone marrow. By which is the most common organism causing infection of erythroid precursors? By parvovirus B19. This is aplastic crisis. All three words are important. Done. This was sickle cell anemia. Next, this gets us to our next hemolytic anemia, that is thalassemia. Now, thalassemia, you very well know that it is of two main types. Let us make a flowchart of the same. It is of two types: alpha thalassemia and beta thalassemia. In alpha thalassemia, alpha chain production is reduced. Versus in beta thalassemia, the beta chain production is reduced. Next point. Most common hemoglobin was HbA, alpha 2 beta 2. In alpha thalassemia, alpha chain production is reducing. So which chain precipitates? Beta chain. So it is associated with precipitation of beta chain. So have a good look at the question. Whether the examiner is asking you reduced production or precipitation. Versus beta thalassemia, which is associated with alpha chain precipitation. It is the alpha chain which precipitates beta thalassemia. Next point, genetics. Next point, genetics. Genetically, alpha thalassemia is associated with deletions. Genetically, alpha thalassemia is associated with deletions versus beta thalassemia, which is associated with point mutations. Next point. Next point. Let us first start. Let us have a look at few salient features of beta thalassemia. In beta thalassemia, the predominant hemoglobin. In beta thalassemia, the predominant hemoglobin is, or let me rephrase this as, in thalassemia major. Let me slightly rephrase this as, it would have been true for both. But let us start with beta thalassemia. Beta thalassemia inheritance pattern is autosomal recessive. So two things can happen. Either it will be heterozygous, that is one allele is normal, the other is abnormal. Either it will be heterozygous or it will be homozygous, that is both the alleles are abnormal. If it is heterozygous, that is one allele is normal, the other is abnormal. If it is heterozygous, it is called as thalassemia minor. Versus if it is homozygous, both the alleles are abnormal, it is called as thalassemia major. Next point, put a double star. Predominant hemoglobin in thal major. Predominant hemoglobin in thalassemia major is HbF. That is the main hemoglobin, or say it will show a presence of 90% of HbF, thalassemia major. Versus in thalassemia minor, again put a double star, HbA2 increases. What do we mean by this? What is normal HbA2? Normally HbA2 is 2 to 3.5%. Versus in thalassemia minor, HbA2 increases. That is, it is more than 3.5%. It is more than 3.5%. These are the hemoglobins in beta thalassemia. These are the hemoglobins in beta thalassemia. Next, versus alpha thalassemia. Versus alpha thalassemia, where alpha chain production was reduced. Alpha chain is needed in both HbA as well as HbF. So alpha chain is reduced, so it leads to the formation of beta 4 and gamma 4. Alpha chain RBC should have 4 globin chains only. Beta 4 is called as HbH versus gamma 4, which is called as hemoglobin parts. Extremely important. This is asked and easy to remember. B and B do not go together. So beta 4 is not HB hemoglobin parts. Beta 4 is HbH. Gamma 4 is hemoglobin parts. Another question that is asked is HbH. It is formed because of deletion of 3 alpha chains. It is formed because of deletion of 3 alpha chains. You very well know that main genetics of alpha thalassemia was deletions. It is associated with deletions. So in our chromosomes, when 3 alpha chains are deleted, in the RBC, it leads to the formation of beta 4. That is HbH disease associated with deletion of 3 alpha chains. This was thalassemia. Next point. Actually, let us have a look at one more feature here only. The screening test of choice. Screening test of choice. Simple one-liner. For hemoglobinopathies, let it be thalassemia or sickle cell anemia, any hemoglobinopathy, the screening test of choice is hemoglobin electrophoresis. Screening test of choice, hemoglobin electrophoresis. Next, this gets us to our next hemolytic anemia, that is PNH, paroxysmal nocturnal hemoglobinuria. PNH, paroxysmal, intermittently at night there is hemoglobinuria. Why? This occurs, PNH, this occurs, remember what was the inheritance pattern? Acquired. So this occurs because of an acquired mutation in PIGA gene. This occurs because of an acquired mutation in PIGA gene present on X chromosome. Acquired mutation in PIGA gene present on X chromosome. Because of this PIGA gene mutation, there is deficiency of GPI-linked anchor proteins. There is deficiency of glycophospholipid-linked, GPI-linked. There is deficiency of GPI-linked anchor proteins. Numerous GPI-linked anchor proteins are deficient. Which is the most significant? Most significant is deficiency of CD55 and CD59. Most significant deficiency of CD55 and CD59. Out of these, which is more significant? More significant out of these is deficiency of CD59. What is the normal group? So firstly, this is PNH. The answers has to be marked in this manner. If PIGA gene mutation is given, you mark that. If that is not in the options, you will mark GPI-linked anchor protein. Otherwise, you will mark CD55 and 59. What do we mean by this? देखो बच्चे, our RBCs, we have CD55 and CD59 on RBC surface. CD55 stands for DAF, that is decay accelerating factor. CD55 stands for DAF, that is decay accelerating factor, versus CD59, which is MIRL, versus CD59, which stands for MIRL, that is membrane inhibitor, of reactive lysis. MIRL, membrane inhibitor of reactive lysis. The normal role of CD55 is it stops the action of C3 convertases. Remember all the complement pathways, they converge on C3. It stops the action of C3 convertases. Versus MIRL, which stops the action of MAC. That is, it stops the action of membrane attack complex. What is MAC composed of? It is composed of C5. A or B, C5B to C9. Easy question. So C5B, 6, 7, 8, 9. Normally, when complement is activated in the blood, CD55 and 59 stops their action on RBCs. But in PNH, patients are deficient in CD55 and 59. That is what we saw. There is deficiency of CD55 55 and 59. So in patients of PNH, when complement is activated, it in turn leads to hemolysis. This is PNH, paroxysmal nocturnal hemoglobinuria. Next point. This gets us to tests for PNH. This gets us to tests for PNH. The first is HAMS test. First is the HAMS test, pretty commonly asked, though it is obsolete, it is not performed now, but it is asked from you guys. HAMS test is performed for PNH. Next, most commonly used test for PNH is the gel card test. Most commonly used is the gel card test. In gel card test, we have small gels which contain anti-CD55 antibody and anti-CD59 antibody in them, which contain anti-CD55 and anti-CD59 antibody. We add the patient's blood. After adding the blood, if ring forms, is it normal? Yeah, normal, because ring will form only when patient's RBCs have CD55 and 59 on the RBC. So if ring forms, it is normal. If it does not form, that means the RBCs are deficient in 55 and 59, which was PNH. So most commonly used test for PNH, gel card test. Next, another test for PNH is flow cytometry. And the last is FLAIR. FLAIR stands for fluorescent pro-aerolysine test. FLAIR, that is fluorescent pro-aerolysine test. FLAIR, which is the most specific test for PNH, followed by the second most specific, followed by flow cytometry. So most commonly used test, gel card test. Most specific test, FLAIR. If FLAIR is not given the options for most specific, followed by flow cytometry. This is PNH, paroxysmal nocturnal hemoglobinuria. And this gets us to our last topic in RBC disorders before we go on to the images and hemolytic anemias, that is AIHA, autoimmune hemolytic anemia. The name tells you everything. Autoimmune, antibody against self-antigen. Autoimmune. So what is the antigen in AIHA? The antigen, it is the RBC membrane. The antigen in AIHA is RBC membrane, very obvious. But which protein? But it is an RBC membrane protein, but which one? The antigen is Band3. What is Band3? This is transmembrane anion transporter. The antigen is Band3. That is transmembrane anion transporter. Next point. AIHA. It is which type of hypersensitivity? 1, 2, 3, 4. You know there are 4 types of hypersensitivity. 1 is asthma allergy. 2, antibody mediated. 3, antigen antibody immune complex. 4, cell mediated. So this is type 2 hypersensitivity. Antibody mediated hypersensitivity type 2. Next point. AIHA. It is of 2 main types. That is, let us make a flowchart of the same. Warm type. It is of 2 types. That is warm versus the cold type of AIHA. In warm type, the antigen, or let me rephrase this as the antibody, is IgG, versus cold, where antibody is IgM. Which is a larger antibody? IgM. It is a large pentameric antibody. It has 5 hits. It is a large pentameric antibody which fixes complement. Versus IgG, which may or may not fix complement. Does not matter. It may or may not fix complement. Next point. Important points are site of hemolysis. In warm type, the most common site of hemolysis is extravascular hemolysis in spleen of the patient. Most common is extravascular in spleen. Versus cold type, which shows both intravascular and extravascular hemolysis, but more common is extravascular hemolysis in liver of the patient. We had seen this earlier also, just 20 minutes before, I guess. So cold type shows both intravascular and extravascular. More common is extravascular hemolysis in liver of the patient. And last point, association. Warm type is associated with the blood cancer. Which one? CLL. It is associated with chronic lymphocytic leukemia. Not much concern with this. Versus cold type, put it over star, which is associated with an infection. Which one? It is associated with mycoplasma pneumoniae. This is asked and is an important point. It is associated with mycoplasma pneumoniae. This is warm versus cold type of autoimmune hemolytic anemia. Next point. So this finishes hemolytic anemias. This was an absolute one of the major topics in RBC disorders, and this gets us again to an extremely important point. That is microscopies. Before we go to the microscopies, let us have a look at test for AIHA also. Test for autoimmune hemolytic anemia. Test used for autoimmune hemolytic anemia. We use Coombs test. Now Coombs test, it is of 2 types. That is direct and indirect Coombs test. Simple funda bache. Autoimmune hemolytic anemia. So do we want to detect antigen or antibody? We want to detect antibody because antigen is present in all of us. It is autoimmune hemolytic anemia, antibody against self-antigen. So we want to detect antibody. Indirect Coombs test, we detect antibody on RBC surface. Versus an indirect Coombs test, we detect antibody in serum of the patient. Versus indirect Coombs test, we detect antibody in serum of the patient. This is Coombs test. This is Coombs test used for autoimmune immunity anemia. Last point. So coming to the microscopies of RBC disorders. Starting with the first one, that is spherocytes. You very well know that spherocytes, they are seen in HS, hereditary spherocytosis, and autoimmune hemolytic anemia. You know this. Next point, Howell-Jolly bodies. Next is Howell-Jolly bodies and cabotrings. Howell-Jolly bodies and cabotrings. Firstly, what are they? They are the DNA remnants. DNA remnants. Senin, both of these, they are associated with megaloblastic anemia. Senin, megaloblastic anemia, and post-splenectomy. Senin, megaloblastic anemia, and post-splenectomy. Howell-Jolly bodies and cabotrings. Next point, put a star. Howell-Jolly bodies, they are also seen in thalassemia. Next is myelofibrosis. If bone marrow is undergoing fibrosis, when the RBCs come out, they become teardrop in shape. Myelofibrosis, associated with the presence of teardrop RBCs, also called as dacrocytes. So myelofibrosis, teardrop RBCs or dacrocytes. Next point. Characteristic RBC morphology associated with megaloblastic anemia. देखो, now usually the answer that I hear is macrocyte, that is, it is a large RBC. In which macrocyte can be seen in both megaloblastic as well as non-megaloblastic anemia. It is a macroovelocyte. It is a large oval RBC, macroovelocyte. Next point. First feature of megaloblastic anemia on peripheral smear. What is the first change that we see in megaloblastic anemia on peripheral smear? We see the presence of hypersegmented neutrophil. First feature is hypersegmented neutrophil. That is, the lobes of the neutrophils are increased. What do we mean by a hypersegmented neutrophil? How many lobes are there? More than 5 lobes in a single neutrophil, or 5 lobes in 5% neutrophils. This is hypersegmented neutrophil. More than 5 lobes in a single neutrophil, or 5 lobes in 5% neutrophils. Next point. Another commonly asked one is basophilic stippling. Next is basophilic stippling, which is seen in basophilic stippling associated with lead poisoning. Next, thalassemia associated with lead poisoning, thalassemia, and megaloblastic anemia. But it has to be marked in this sequence. That is, most common cause of basophilic stippling is lead poisoning. If that is not given in the options, other causes are thalassemia and megaloblastic anemia. Done. This takes care of main RBC morphologies. So this starts us with the microscopic features. Starting with the first image. Now here the RBCs are blue in color. They are not red. Normally they should be red, means it's a special stain. Which one? It is a supravital stain. New methylene blue. It is a supravital stain. Most commonly used is new methylene blue, showing the presence of reticulocytes. How many reticulocytes are there? Any RBC with a central blue dot. 1, 2, 3, 4, 5, 6, and 7. So there are 7 reticulocytes in this slide. These two are not. There is no blue dot in these two RBCs. Other than that, everything was a reticulocyte. That is supravital stain. Next point, diagnosis. This is a spotter. The minute you see this, you are able to make out that these RBCs, they lack the central one-third pallor. That is, all these are the spherocytes seen in HS and autoimmune hemolytic anemia. Next, diagnosis. Now have a look. Firstly, the RBCs. This slide was just shown to you to show you the normal size. Next, diagnosis. Now have a look. First, spherocytes seen in HS and autoimmune hemolytic anemia. Next, diagnosis. Now have a look. Firstly, the RBCs. This slide was just shown to you to show you the normal size and shape of an RBC. This is the normal size, normal shape with central one-third pallor. Look at any RBC. Next, all these small are the platelets. These are the platelets versus this cell, which is a lymphocyte. This is a lymphocyte. So diagnosis. This is a nice normal peripheral smear. Nice normal peripheral smear to show you the normal size and shape of RBC. Next one. As compared to normal, look at this. What is the problem? This is again a spotter. You are able to see the presence of RBCs in which bite has been taken. For those of you who use Apple products, iPad, iPod, iMac, whatsoever. So bite cells seen in G6PD deficiency. Bite cells seen in G6PD deficiency. Next, this was a normal size and shape of an RBC, differentiated from this one again. This is again a normal, showing you the presence of all these. All these are the sickle-shaped RBCs. All these are sickle-shaped. That is sickle cell anemia. This is platelets. All these small ones, they are the platelets, whereas this is a neutrophil. Next, test used. You can simply be asked this. Test used. This is Nestrov. Naked eye, single tube, red cell osmotic fragility test. Now, Nestrov, this is used for thalassemia. If I'm able to see a black line for this, another question that is asked is what is the concentration of sodium chloride used? We use 0.36% sodium chloride. Next, this is an osmotic fragility test, that is, it is associated with reduced osmotic fragility. Next point. If a black line is visible at the back, that means that hemolysis has occurred, meaning this is normal. If I'm able to see a black line at the back, just remember it as a fact. Forget the funda at this point. We did that in normal. So if I'm able to see, we add 0.36% sodium chloride and in the blood sample of the patient, and I put a black line. And if I'm able to see black line at the back, it is normal. Whereas if I'm not able to see black line at the back, this is a case of thalassemia. This is thalassemia. This was Nestrov. Naked eye, single tube, red cell osmotic fragility test. Next point. Diagnosis. Remember normal. As compared to normal, these RBCs, they are large and oval in shape. Macroovalocytes, which is a feature of megaloblastic anemia. Macroovalocytes, which is the characteristic RBC morphology in megaloblastic anemia. Next, a spotter. Which cell is this? This is a neutrophil. How many lobes? 1, 2, 3, 4, 5, 6. More than 5 lobes in a single neutrophil. Hypersegmented neutrophil, which is the first RBC morphology or first change seen in megaloblastic anemia. Next, diagnosis. As compared to normal, what is the size of the RBCs? They are much smaller, and central pallor is more than 1/3. They are much smaller with more than 1/3 central pallor. Microcytic hypochromic RBCs. Most common cause being iron deficiency anemia. And this gets us to the last RBC morphology, that is diagnosis. First, identify the abnormal morphology. To identify the abnormal RBC, it is this one, showing the presence of oval jolly body, an important finding. Done, bache. This takes care of RBC disorders.
This gets us to our last session of pathology with respect to hematology, that is bleeding disorders. So let us start with bleeding disorders. You know that normally there are two plug formations, the primary hemostatic plug and the secondary. Primary hemostatic plug formation has 3 steps: platelet adhesion, platelet activation, and aggregation. Platelet adhesion, this is mediated by von Willebrand factor present on endothelial cells binding with GP1B present on platelets. This is platelet adhesion. This leads to platelet activation, which causes recruitment of platelets and release of granules, and release of granules, in turn leading to platelet aggregation, which is mediated by GP2B3A present on platelets. Next one, these are the three steps in primary hemostatic plug. So there are 3 diseases associated with it. Deficiency of von Willebrand factor is associated with von Willebrand disease. Deficiency of GP1B is associated with BSS, that is Bernard-Sollier syndrome. All these are the one-liners. It is associated with BSS, that is Bernard-Sollier syndrome. And deficiency of GP2B3A is associated with Glanzmann's thromboasthenia. Next point. This was primary hemostatic plug, which in turn progresses to secondary. Secondary hemostatic plug has 2 pathways, an intrinsic and an extrinsic pathway. Extrinsic pathway is mediated by tissue factor
binding to factor 7. Extrinsic pathway is mediated by tissue factor binding with factor 7, which progresses to the common pathway. Common pathway, the first step is factor 10 to 10A conversion, which needs three things. That is factor 5, calcium, and phospholipids. 10 to 10A needs three things. That is factor 5, calcium, and phospholipids. Factor 10A, that is activated form of 10. Factor 10A converts prothrombin to thrombin. It converts prothrombin to thrombin, which in turn leads to the conversion of fibrinogen to fibrin, which leads to the conversion of fibrinogen to fibrin. This is extrinsic plus common pathway versus the intrinsic pathway versus the intrinsic. So this is intrinsic, extrinsic, and the common pathway. Intrinsic pathway starts from factor 12. It starts from factor 12. Let me use a slightly different pen for this. Starts from factor 12 to activating factor 11. Factor 9-8 complex in turn going to factor 10. So first question, which population factors are involved in intrinsic pathway, which are in extrinsic, which are in common pathway. The 10 to 10 conversion was the common pathway. Next point, test used for intrinsic pathway is ABTT. Test used, activated partial thromboplastin time, also called as PTTK, partial thromboplastin time with colon. Not interested in the full forms ABTT or PTTK. Versus test for extrinsic pathway is PT, prothrombin time. Next, this was the basics. Next, let us have a look at coagulation factors. All clotting factors are synthesized in liver, except factor 8. Factor 8 is factor 8A. Factor 8 is factor 8A plus von Willebrand factor. Von Willebrand factor is synthesized by endothelial cells. Von Willebrand factor is synthesized by endothelial cells. Next point, least half-life factor 7. Least half-life factor 7. How much? It is 4 to 6 hours. Versus maximum half-life factor 13. How much? 11 to 14 days. Next, vitamin K dependent factors. They are factors 2, 7, 9, and 10. Vitamin K dependent 2, 7, 9, 10. Next, protein C and protein S are also vitamin K dependent. Protein C and S are also vitamin K dependent. Next, hemophilias A, B, and C occur because of deficiency of factors 8, 9, and 11. A is 8, B is 9, C is 11. So I can safely say that factor 9 is the anti-hemophilic factor B, also called as Christmas factor. It is the anti-hemophilic factor B, also called as Christmas factor. This was the basics of clotting factors. Next point, few one-liners. Anticoagulant of choice for coagulation tests. Coagulation tests are your PTTK. The anticoagulant of choice is trisodium citrate. So I can rephrase this as trisodium citrate plays two main roles. It is used in coagulation tests and ESR. The ratio is different. Ratio of anticoagulant to blood coagulation test is 1:9, which is very, very important. Versus for ESR, it is 1:4. That is more anticoagulant is needed for ESR, 1:4 in ESR. Lastly, for the coagulation test, the sample that we use is platelet poor plasma. We use PPP, that is platelet poor plasma as the sample. Next, so this gets us to a master table of bleeding disorders. Let us make a table with headings as PT, PTTK, platelet count, and diseases associated. Starting with the first one, that is PT is increased, PTTK is normal, platelet count is normal. Diseases. Answer which PT was in the extrinsic pathway is factor 7. That is the factor with least half-life. So early vitamin K deficiency. It was vitamin K dependent. When vitamin K deficiency starts, first to reduces factor 7 leading to increased PT. Next, all coagulation factors are synthesized in liver. So early liver disease. In liver disease, first to be affected will be factor 7. Next is PT is normal. PTTK is increased, platelet count is normal. Diseases. Now PTTK was involved in intrinsic pathway, that is factors 8, 9, 11. So these are your hemophilias. These are the hemophilia A, B, and C. Hemophilia A, B, and C. Next, isolated elevation of PTTK is also seen in von Willebrand disease. So hemophilia and von Willebrand disease. Next is increased normal. Both PT and PTTK are elevated. Platelet count is normal. Disease both are elevated in when there is a deficiency of both intrinsic and extrinsic pathway. That is chronic liver disease. In early liver disease, factor 7 is the first to be affected, but gradually other factors will also reduce. Chronic liver disease and late vitamin K deficiency. Early was isolated deficiency of factor 7, but gradually other 2, 9, and 10 will also be affected, leading to elevated PTTK. And the last is PT and PTTK are increased, platelet count is reduced. This is the classical picture of DIC, disseminated intravascular coagulation. DIC. These are the main points with respect to bleeding disorders. Next point. This gets us to our last topic in pathology, that is blood banking. Starting with the Bombay blood group. What is Bombay blood group? An important concept. In this, H antigen or H substance is absent. Now, if H antigen is absent, there is absence of A and B antigens also. So A, B, and H antigens are absent. There is no antigen. So all antibodies are present. Anti-A, anti-B, and anti-H antibody. All the antibodies are present. Next point, Bombay blood group. It can only be transfused with Bombay. That means a Bombay blood group patient can receive only Bombay blood group, but can donate to all. It can receive only from Bombay blood group, but can donate to all. And last point, deficiency of other blood group antigens, the minor blood groups, Kell, Duffy, RH, Mn. All these are the minor blood group systems. They are not seen. Deficiency of minor blood groups are not seen. This is Bombay blood group. Next, coming to the shelf life of various preservatives, there are 4 commonly used: ACD, acidified citrate dextrose; CPD, citrate phosphate dextrose; CPDA, citrate phosphate dextrose with adenine; and SAGM, sodium adenine glucose monomer. Shelf life. The shelf life is in multiples of 7, 21 days, 28 days, 35 days, and 42 days. So I can safely say longest shelf life. I can safely say longest shelf life SAGM 42 days. Most commonly used CPDA shelf life 35 days. Next, this gets us to components of blood. Let us have a look at 2-3 main components. Starting with, firstly, we do not transfuse whole blood now. What we give are the components. Starting with packed RBCs. Now, giving 1 unit of packed RBC increases hemoglobin by 1 gram per deciliter and hematocrit by 3%. First point. Next point, storage temperature. They are stored at in the fridge. They are cold. That is 2 to 6 degrees Celsius with an average of 4 degrees. Shelf life depends on the preservative used. We have already seen that. Next point, it has to be transfused within 4 to 6 hours of collection from blood bank. Has to be transfused within 4 to 6 hours of collection from blood bank RBCs. Next is platelets. Now I can divide the platelets into random donor platelets and single donor platelets. Random donor means different people donated versus single donor platelets, which are obtained from platelet transfusion which are obtained from platelet apheresis from a single donor platelet. Firstly, random donor giving 1 unit increases the platelet count by 10,000 per microliter versus single donor, which increases it 3 to 5 times, 30 to 50,000 per microliter. Next point, volume of random donor is 50 to 70 ml versus single donor, it is 3 to 5 times, that is 200 to 300 ml. Next point, very, very important, platelets, storage temperature. They are stored at room temperature. That is 22 to 24 degrees Celsius. And shelf life. If something is at room temperature, it will go bad in 5 days. Shelf life, 5 days. Shelf life, 5 days. These are the platelets. Next, this gets us to our next component of blood, that is FFP. Fresh frozen plasma, FFP. Now the name tells you the plasma is freshly frozen, fresh frozen. So plasma is frozen within 6 hours of collection. It is frozen within 6 hours of collection. Storage temperature, it is frozen. Storage temperature minus 30 degrees Celsius. Shelf life 1 year. If something is in deep freezer, shelf life is 1 year. Next point, it is rich in all coagulation factors. It is rich in all coagulation factors except it is rich in all except factors 5 and 8. This is FFP, fresh frozen plasma. It is rich in all coagulation factors except factors 5 and 8. And the last is cryoprecipitate. Last component of blood, cryoprecipitate. This has precipitated proteins. This contains precipitated proteins from FFP. It contains precipitated proteins from FFP. Next, again put a double star. It is rich in von Willebrand factor, fibrinogen. It is rich in von Willebrand factor, fibrinogen, factor 8 and factor 13. It is rich in 4 things: von Willebrand factor, fibrinogen, factor 8 and factor 13. Next, cryoprecipitate. Again, deep freezer, minus 30 degrees Celsius, and shelf life 1 year. Shelf life 1 year. Done. This takes care of your main components of blood banking, and this finishes pathology. So 3 words which often help me: pray often. Prayers, they have huge positive energy. Work hard and trust God. Everything will work out well. Take care and best of luck.